2018 to 21. She has been a vice president in 2016. She doesn't need an introduction actually. We have been doing webinars and physical series with her so many times. She is the ICOG Governing Council member, having won the Best Governing Council Award in 2021. She has been the corresponding national editor and peer reviewer for the journal OBGYN India and Journal Suffolk. Foxy past chairperson Safe Motherhood Committee with Foxy Dr. Mehru Dara Hansotia Award for Best Committee Activity. Thrice she has represented our country to WHO on key women health issues, and she has won 3 times the Korean Award for Best Scientific Research Paper in 2002, 2004 and 2009. 4 times she has won the Best AICOG Research Paper Award. She is the sole author of the book Caesarean Delivery, Vaginal Delivery, a comprehensive textbook for OBG. She has been the editor for 7 Safe Motherhood Bulletins, ICOG Campus and Foxy Focus, and book Safe Motherhood Initiative. She has been awarded 3 times the Foxy Dr. DC Datta Prize for Best Foxy Publication and Manual. She has been awarded the Chancellor's and Dr. Naval Kishore Gold Medal for Best MBBS and Postgraduate Student. She has been the key organizer for many national and international conferences, and the list goes on. Over to you, Sadhana Madam.
Thank you, Shalja, for your loving invitation and always being together. So please stop slide share. Please, Saiti, please stop slide share. So I warmly welcome our chief guest, Dr. P.K. Shekran, our guest of honor, Dr. Vidya Thobi, and all president and secretaries of Bengaluru, Bellary, Mangalore and Manipal Society, Dr. Shubha Ram, Dr. Indra Reddy. We were just together just 2 days ago. Dr. Samaju, Dr. Sweta, Dr. Shiv Kumar, Dr. Panita from Bellary, Dr. Arun K. Kamath, Dr. Swapna from Mangalore, and Dr. Rajesh and Dr. Anjali from Manipal. So it is because all your effort and all your coming together is the thing what we keep us going and keep us spreading knowledge and the skills on many fronts for the benefit of everyone. A little word about the E-Classic for clinician, because in this journey, in the long journey, as in Foxy, as in the personal level, what I feel that now that today we are having an ever-changing evidence and ever-changing issues, and our average clinician is getting confused that what to do and what not to do. So the classic teaching remains, and our seasoned teachers like Dr. P.K. Shekran and Dr. Vidya, they are always concerned that the residents and the postgraduates are not like having that strong foundation of the basic teaching, which actually gives the foundation stone for the all evidence, for all the new thing which is coming. So we are really focusing and having the best of brains and the faculties in this E-Classic for clinician for giving a very clear message to our all clinicians who are working in diverse practices. So again, gratitude for being together, and it is a great pleasure to have Dr. P.K. Shekran as a chief guest of this this series of E-Classic for clinician. Dr. P.K. Shekran I have been seeing when I entered Foxy, I looked to him for all data collection he taught, and he used to teach me so many things that how can you organize the things at the professional organization, how to work with them. And it is so great to have the mentors and the teachers like Dr. P.K. Shekran. He has been the former professor and head of the department, Government Medical College, Calicut, President, Kerala Federation of OB-GYN in 2003 and 4, Vice President, Foxy 2010, from where I have the association right from that time, organizing chairperson of the World Congress of the GTD, Secretary and Treasurer for the International Society for the Study of GTD, co-author FIGO guideline on management of GTD, and a lot of publication with 407 citations, which tells a volume about the Dr. Shekran's research capabilities. Again, gratitude, Dr. P.K. Shekran, for your precious time, and we look forward to listen for your pulse of wisdom on all the endeavor which we are doing and on the subject as well.
Thank you, Dr. Sadhana. First of all, let me thank you profusely for giving me this honor to be amongst with you all. And I am happy to see we are having a workshop on Caesarean section. We are having 5 societies from Karnataka, Bangalore, Bellary and Belgaum, and Manipal and Bangalore. I had been to all these societies several times, and we have got the state president also with others, and welcome you all to this wonderful workshop. Caesarean section, we know that is a life-saving procedure for both mother and baby. We are all aware of it, but at the same time, we are all concerned about the rising section rate nowadays. If you look at the progress of medicine, at least 10% of cesarean section is essential to reduce the maternal morbidity and perinatal morbidity and mortality. If you go beyond 10%, it will keep on increasing the result even up to 30%. That is what we have seen over the so many years. Beyond 30% incidence, I am very doubtful whether we are improving the maternal and perinatal outcome. Probably a few more sections are required. At the same time, cesarean section is the only way to deliver a healthy baby in a given situation also. So that also we are aware of. So we have to have our decision making in doing a cesarean section, because we are seeing many complications following cesarean section also. Even reports are there of maternal death following an elective cesarean section also. So we have to be extremely careful in selecting the cases and performing the surgery, though this is the most common surgical procedure that we are all doing nowadays. I thought earlier that it was the DNCs that we have done. I think nowadays we hardly do any DNC, but the section rate is so high that we have to be sure about what we are doing, so that both the mother as well as the baby is safe. Now, there may be many reasons that we can say excuses because the section is increasing. Probably we can blame the ARTs and MRTs or the increase in the incidence of twin pregnancies. But the most important factor is the previous cesareans coming to us, where we are not able to keep them for a vaginal delivery. We were doing vaginal deliveries for a section, but there is an associated risk in keeping a patient of previous cesarean for vaginal delivery. I have done many, but occasionally I also had landed in trouble. Nowadays, nobody is going to take any risk. Even that 0.4 risk of a rupture, nobody is going to accept that. So, and we are also not able to take that risk. With that result, the suction rate is 35, 40, 45, 50. I don't know where we are going to stop. For which the government, the press, the media, and we are also concerned. So cesarean section is an important surgical procedure that we have to do, and it is the day-to-day work that we are doing. Bulk of it time goes for doing cesarean section and looking after the patient. We can't help it, but how to bring it down should be our concern, and we are all concerned about it. I don't know where we can cut down the rate with this. I don't know the patient's demand is an important cause of increase in section. I don't think so. Probably you may be all having that incidence. But in my practice, hardly anybody has asked for a cesarean section as in lieu of vaginal delivery. Even if they ask for it, if you convince them that you can have very good pain relief and will be looked after during labor and afterwards, probably many of them will be accepting a vaginal delivery, even if many are concerned about especially the pain, afraid of pain and other problems. So we can console them, convince them that it can be done without pain, and that is how we can proceed it. I am too happy to see that there are very many good topics or also part of the Caesarean section is being covered. I don't want to interfere with your program. I wish all the best. Especially, I wish the very best for Dr. Sadhana Gupta in her coming election, and I hope that you make it. Thank you very much, you all, respected colleagues and friends, and we will listen to the scientific deliberation. Thank you once again for the kind invitation and giving me the honor.
Thank you, Dr. Shekharan, for your words of caution and words of concern. And thank you very much for your precious wishes, which makes a lot of motivation and inspiration for us. Thank you, Dr. P.K. Shekharan, once again. It is a great pleasure to have Dr. Vidya Thubi with us, a very, very close friend, and she has been just taking charge as a president of Karnataka Association of OB-GYN, Kasoga, what is called fondly. And she is professor and unit head, Alameen Medical College, Bijapur, Karnataka, chairperson. She has been the chairperson food. A very impressive Foxy Food, Drug and Medical Surgical Equipment Committee with the Best Committee Award for Dr. Maradora Hansuria Award, which is one of the very prestigious award of Foxy for the chairpersons. ICOG Governing Council member, Foxy Champion Award, National Corresponding Editor of Jogi and Organizing Chairperson Kasoga 2016. She has been President Bijapur of Gynae Society and the Secretary as well. Numerous publications and papers, and organized many conferences. She has been the advisory faculty for Rajiv Gandhi University of Health Sciences Board and a postgraduate and undergraduate. A great teacher. So Dr. Vidya, it is such a great pleasure to have you today, and we look forward to listening to you.
Yeah, thank you, Dr. Sadhana, for those nice words, and it is always a pleasure to be associated with you. I know Dr. Sadhana Gupta for more than a decade, and she is such a good academician and wonderful a person. And really, I wish all the best for her future ventures. And her topics, whenever she selects any topics for any workshop or any CMEs, and I have seen her throughout her journey of Safe Motherhood Committee, she brought so many publications, books. So they were so practical. And I always refer those to my postgraduates as well. Today also she has chosen a very good topic, that is Caesarean section, which is really useful for all of us. And we all, and I'm very happy to share a dais with P.K. Shekharan sir. He is also my teacher. Across webinars, of course, I have not been taught by him, but many times I take so many tips and tricks from his lectures. So he is a teacher of teachers, and also Sadhana has chosen so many good speakers amongst Karnataka and other state, Papa Dasri and others. So it is a very good, going to be a great webinar, I must say. Today's topic about P.K. Shekharan sir also talking about reducing the Caesarean section rates. We are always talking about this, and most commonly I ask my postgraduates, what is the first? That is, they say that Caesarean delivery on maternal request. Our counseling, the communication skills are going down. And what about rates? We are talking about, we have to abide by 15%, whether it is possible. And it all depends on the patient population, circumstances, availability of anesthetist. Then we are really afraid of the medical legal consequences. If something happens to the fetus and something happens to the fetal distress and baby dies, so many times the CTG monitoring is not there. Many times we don't want to monitor. There is an obstetrician distress rather than the fetal distress many times. So these are the reasons for which we are afraid of. The Robson classification has come, but there are many pitfalls for the Robson classification where we know that, and most of them, the indication is another indication I want to tell is failure of induction of labor. So really, what are the methods of induction of labor? What is the monitoring method? We have to really look into it. Caesarean audits are very important. We don't audit ourselves. What are the reasons and how it can be prevented? We don't teach about these things. And of course, we are always talking about the complications like placenta accreta, spectrum disorders, and all those things. We have forgotten the art of vaginal delivery. So the assisted vaginal deliveries, forceps, vacuum, again, we have to teach them properly, when to apply, documentation, all these things are very, very important. And I again congratulate Sadhana to bring out these issues in various panel discussion and various talks. So I'm really eager to listen to all the talks, and I would love to participate in between. I don't want to take much time, and I wish Sadhana ji all the best. And I welcome all the people from Karnataka, then Tamil Nadu, everyone who are very eager to listen to it. So thank you very much, Sadhana ji, for inviting me. And really, it is a pleasure to be amongst all of you. Thank you very much.
Thank you, Dr. Vidya. Thank you for your pulse of wisdom. And again, it is really great to have you throughout the webinar. So thank you very much, Dr. P.K. Shekharan. Thank you very much, Dr. Vidya. So Ritu, you can go ahead.
Yes, ma'am. Thank you very much.
Ritu madam. Ritu
Yeah.
madam, Dr. Manimani has joined through her phone, but she'll be there with her laptop in a few minutes. She wanted to do her session as the second one.
As a second
Sadhana,
one.
it's okay. You
Okay.
can start the session.
Yes,
No
yes,
problem.
yes, yes, I will.
Madam, are you willing to?
Yes, it's
Yes,
okay.
okay, ma'am. Yeah, good evening. It's a pleasure welcoming all of you to the scientific session of Caesarean section workshop. In the since Dr. Manonmani is not ready with her things, so I invite Dr. Sadhana Gupta ma'am for her talk. That is the second talk in our session. And the second talk is on, yeah, the second talk is on the standardization of Caesarean technique to prevent scar defect. And to grace the occasion, our chairpersons are Dr. B.K. Anupma Sundar. Madam is consultant at BKS Hospital, Bellary. She's a joint secretary, WDW-IMA. She has worked in United Kingdom and has many publications in journals and has organized many camps in social awareness. We welcome you, ma'am. Then Dr. Ashraf Ali. Sir is a specialist at District Hospital, Bellary. He is a treasurer of Bellary Society. He is a master trainer for comprehensive abortion care service. We welcome you, sir. Then Dr. Shweta Patil. She is the director of Jiva Fertility and IVF Center and is associate professor at Belgaum Institute of Medical Sciences. She is honorary secretary in Belgaum Society. She is presently the joint secretary also, and she is a life member of Indian Society of Gynecological Endoscopy, and I welcome her also. Now I request Dr. Anupma Sundar to please introduce the speaker, who is none other than Dr. Sadhana Gupta.
Yes.
Madam, over to you.
Good evening, everybody. It's my great honor and pleasure to introduce Dr. Sadhana Gupta, madam. She needs no introduction, but a small one so that we can start the session. She has been a co-chair Suffolk NCD committee, Foxy representative to Suffolk 2018 to 21, Vice President Foxy 2016, ICOG Governing Council member with Best Governing Council Award. She has been a Foxy past chairperson for Foxy Safe Motherhood Committee. She has thrice represented our country to the World Health Organization, which is really a great achievement. 3 times Caesarean Award winner for Best Scientific Research Papers, 4 times Best AICOG Research Paper, solo author of so many books, and she has had so many awards that you can see as put up on her CV. 3 times Foxy Award, Award of Chancellors, and Dr. Naval Kishore Gold Medal for Best MBBS and Postgraduate student. She has been a key organizer of so many national and international conferences, including as an Adolescent Congress in 2002, and the latest being the Abigyan Foxy Figo Suffolk 2021. She has given innumerable orations And she has been honored at national and international forum for exemplary work done to reduce maternal mortality, community services, and women empowerment, namely Foxy Padma Bhushan Kamlabai Hospital Award, Foxy Dr. R.N. Malhotra Award, and Foxy Dr. Durusha Award for Distinguished Community Services. She is an awardee Foxy Super Achiever Award 2023, Pride of Foxy Award 2019. She is a recipient of Dr. the N.A. and Shailaja Pandit Award for Women Empowerment 2021, Economic Times Award for Services in COVID times, and the list goes on. And she is Director and Senior Consultant OB-GYN, Jeevan Jyoti Hospital and Medical Research Center, Gorakhpur. It's a great pleasure welcoming you, ma'am, and we are looking forward to hear your lecture. Thank you.
Kind introduction. Thank you, Anupama, for very kind introduction. And again, my regards and thanks to our dignitaries, all faculties, and all office bearers. So Dr. Manumani is actually in some official function, and she has come from the place. So I'm taking that this was on the second in line, right from indication. So I will be dealing that, I will be merging actually two topics, the cesarean section technique standardization, and actually that technique can reduce the all spectrum of the scar complication or not. So this is something, the challenges as well as the solution. So thank you always for being together. It has been great journey, and actually I always that gratitude that actually it is the southern people, Dr. Kamini Rao, Dr. Hema Devakar, Dr. Pratap, who actually picked me when I was very young, and it has been a wonderful association. And southern with the wonderful maternal and newborn and the health statistics and women empowerment, South has has to do much more on the national and international platform, because the southern experience, especially about that why mothers die, that this confidential inquiry into maternal death, that is the something to play a great role in not only in India, in our country, but also across the region. So I've been greeting from the land of Buddha, who says we can never obtain peace in the outer world until we make peace with ourselves. So it is all important thing while we are doing cesarean, taking decision for cesarean section or as a doctor. So cesarean section is something very unique surgery for society and civilization, always involving two lives, giving birth and having birth, which is considered the most difficult journey in human beings, and it is done not for the disease but for the physiological process of reproduction, accounting for around 30 million surgeries. And it is always what we are talking about, the rising rate of cesarean section, because from the life-saving last attempt to save the mother's life, it is now the cesarean section people are demanding, because they consider it is safe and the convenient. So it is always evolved in the backdrop of women empowerment and reproductive and sexual rights. A lot of issues about the high incidence of cesarean section. Important thing, WHO as well as Foxy says that we should not run after a particular rate of cesarean section, but any woman who needs cesarean section must have the quality to access the good quality cesarean section in the good setting. And this is important, that it is not every woman should have expectation of the successful and safe vaginal delivery, but always the right to access to a good cesarean section. So why as a clinician we are considered? It is a cost on our national system, our health system, on the family, more maternal morbidity and mortality as compared with vaginal delivery, more perinatal morbidity sometimes can occur because of the iatrogenic prematurity or a long-term neonatal health issue. And what is actually most important, which is troubling us as an emerging cause for the maternal criticality and the mortality as well, that the cesarean scar complications, cesarean scar defect cesarean scar and all placenta accreta spectrum. And actually, we don't know what are the diagnostic modalities and the management modalities. So cesarean section is not just a cesarean section. It should always remain a just cesarean section, and the scar complication can be immediate and the late. These are not old papers. These are the new papers which are especially from the tertiary care setting, that post-cesarean we can have a lot of problem. So coming to the immediate complications which can happen into the cesarean, that is the infection which is related to prolonged labor, prolonged rupture of membrane, prolonged surgical time. And actually why it is infection? Because it can cause to the poor wound healing. We can present mild wound infection to the sometimes the spectrum of necrotizing fasciitis, and what we know that what are the standard measure to take it, wound swab, good antibiotics, sometimes surgical thing, and what we have to do if we face with a surgical site infection. But what message I want to give, that we are actually abused for the for having the injudicious use of antibiotic. So in cesarean section, one message is that the prophylactic IV antibiotic to be given women at the time of cesarean section, that result into 60 to 70% reduction in incidence of postpartum infection. The second thing, that the antibiotic to be given 30 to 60 minutes before incision, and the usually it is the single dose or the for period of 24 hours. But if it is high risk factor, what is the PROM, what is obesity, diabetes, then you can go for the 5 days course for the antibiotic. Cephalosporin second or third generation, what we are giving, if MP gentametrozole is available in public health setting, it is also okay. We cannot go away with the universal safety precaution, adequate biomedical waste disposal, not only in the cesarean section operation theater, but in the labor room as well. And we have to be very strict for the labor room protocol. Now coming to the scar, that can be the life-threatening complication, that is postpartum uterine dehiscence. And these women come as a dicey situation. Like they come to us as a recurrent postpartum hemorrhage or pelvic pain as early as 10 days to 12 weeks after surgery, or the dysmenorrhea or the irregular bleeding. I just wish to say to all audience that if you find, because many times we are looking for the intrauterine, there are retained product of conception, or there is something wrong in the uterus. But if you see that there is a presence of bladder hematoma, pelvic hematoma, presence of gas into uterine cavity, which is going into endometrium, be careful that you are dealing with some sort of postpartum uterine wound dehiscence, and that is due to the poor wound healing. So it can present to you as a life-threatening situation, and you have to take the good decisions, like doing, if the patient is unstable, sometimes only hysterectomy help. If patient is stable, we can use the intervention, radiological issue intervention. The pseudoaneurysm is one thing, again, what our clinicians are getting, because we are having a AV malformation, and we are really worried and we are fearful. We are afraid to take the patient for any diagnostic curettage because it is showing any AV malformation or the pseudoaneurysm. So this is important that we diagnose these pseudoaneurysm well with the good ultrasound setting. And this is the picture. Actually, it is not the only increased vascularity which is synonym with the AV malformation. It is a typical pattern that is yin and yang. You will see the turbulent flow going on, and that is pseudoaneurysm, and that can also present to you as a life-threatening hemorrhage. Long-term scar complication, which is actually forcing us to think for the reduction in the cesarean section rate, is the all spectrum of the placenta accreta spectrum, which start from the scar niche and goes into the scar pregnancy as the placenta accreta spectrum. So the post-cesarean niche or the sthymocele, which result from the suboptimal technique and timing of cesarean section, is the bed for all placenta accreta spectrum, And as a clinician, we should be aware of this entity. When the patient is well, she is coming to us after 10 to 12 weeks of the surgery, and we should be aware in our gynecology as well as the infertility practice. We have a lot of issue why few patients have these scar niche, and why the patient have the something genetic or constitutional or the some optimal technique for the cesarean section as a etiopathogenesis. But the uterine niche is a very common reality which is around us. We name it as isthmocele, scar defect, uterine dehiscence, and the diverticulum. And you see as a triangular hypoechoic or anechoic shadow. The imaging modalities are not very high, no costly. It is a simple transvaginal sonography or sometimes sonohistography, which sometimes add to your diagnosis. More number of cesarean section, there are more chances that you have the more chances of the scar defect. So what this scar niche is the bad for the cesarean scar pregnancy, for the placenta accreta spectrum, and the risk factor are in the previous cesarean section, which can be surgery related as well as the patient related. So if there is a well-healed scar, you will find only a small indentation at the proposed uterine site, what is the usual uterine incision site. But if it is scar defect, it is an irregular oval hypoechoic shadow, which you can see at the incision line, what we usually give at the lower segment. What can be the risk factor? Adhesion, retroflex factor, because that cause the counter current fracture and the less blood supply to the uterine bone, and that leads to the weak scar. Genetic predisposition, we cannot do anything about genes, gestational diabetes or the frank diabetes, previous cesarean section, higher BMI, and longer active labor prior to emergency cesarean, that add to the increased chance of the niche formation. So this is very important, and how the technique standardization of cesarean section technique and timing can help us in reduction of this placenta spectrum is very, very important. Cesarean section, whether it is an elective or advanced labor, both situation what we take as a difficult situation in cesarean actually lead to the poor wound healing and the scar defect. So it is better, what the people always say, that do cesarean when the pain starts. It's not now, but actually 10 years ago, people used to say, when pain will occur, I will come. They were quite okay. They were quite intelligent, because at that time we have a good lower uterine segment formation and we place the incision at the right time. More number of increasing maternal age, more number of cesarean section, more number of induced abortion. And I'm really sometimes concerned that a very, very high incidence of medical abortion might doing something to this also. Place of cesarean section, this is also very, very important, very good paper from the China, because we have to see our things as a scientific manner. So government is pushing us everywhere. We should have the facility for cesarean section, but we don't have that infrastructure. We don't have the trained obstetrician or the surgeon, and that can lead to the increased incidence. And this paper says very boldly that the cesarean section at rural community hospital is found to be independent factor for the cesarean scar pregnancy. So we cannot do with the non-modifiable factor, which is age or retroversion of uterus, but the labor-related thing we can change. So the cesarean section closest to the term and not in the very advanced stage of labor, and the technique of the cesarean section, especially the uterine incision and the closure technique. They can present to you as asymptomatic, pre-post menstrual spotting, prolonged bleeding, intermittent spotting, pain, and the mid-cycle intrauterine fluid accumulation. So in gynecological practice, we are having these issues, and the chronic pelvic pain, when we are treating with the empirical diagnosis or taking that the patient is having some sort of endometriosis, we must think the possibility of scar niche in our diagnostic workup. Patient can present to you with the secondary infertility and the IVF problems, because we are not able to have an easy IVF embryo transfer and the higher IVF failure, bladder dysfunction, as well as the scar abscess. So it is a obstetric what we say, the gynecology is the legacy of obstetrics. And this scar niche actually tell what is happening in the previous surgery, previous cesarean section, and now the patient is having a lot of issue. We can have all the complication, this scar pregnancy, placenta scar dehiscence, uterine rupture, and the placenta accreta syndrome. And we have very good paper right from our own India, Vidushi from the AIMS Delhi and from the abroad. And important thing is, this is very, very important paper from Indranil Datta from our own country, from West Bengal, that patient comes to us as a scar pregnancy or some scar defect as a life-threatening hemorrhage because she has taken either the medical abortion pill or she has been diagnosed as a missed abortion, and suddenly the obstetrician encountered life-threatening hemorrhage. So it is something which we have to deal with it. That scar niche is reality. It is not that very uncommon. And when it is a small, it is more than 50% of myometrial thickness is involved. We say it is a large niche. And Dr. Alka Kriplani gave a wonderful, like she has collected many patients, because just to emphasize that she has such a large series of what she's like managing laparoscopically for the different variety, outward, inward, minor, and the major degree of the scar niche. And we have to be aware of it. Not every woman needs the treatment for the scar niche. Only when it is symptomatic, it is pelvic pain, it is infertility, then we need to treat it medically. We can use COC and the uterus sparing surgical technique. So if it is accessible from below, you can excise, resect by hysteroscope, otherwise laparoscopically, sometimes laparotomy also. Then we can do the niche repair and the hysterectomy. So actually it is a learning curve. It is not that every endoscopic surgeon can do it. We must need, because it is a new thing which we are coming across, and we must be open that what our experience tells us. So how we can prevent these all spectrum of the thing scar niche to the placenta accreta spectrum. So primary prevention, what Dr. P.K. Shekharan, Dr. Vidya says, that minimize primary cesarean section. We cannot go away with that. Government, media, everybody is with after for us that what we are having, and we have to have a very good audit for cesarean section indication, incidence, and the secondary prevention, which is a good or the alternative surgical technique which ensure the thicker residual myometrium and a good wound healing. So strong scar remains the mainstay in prevention of niches and the subsequent complication, which we have to remember day in and day out when our right from the resident to very senior people are doing cesarean section. So cesarean section at right time and the level of uterine incision at the right place. If you place the uterine incision toward the cervix, it results into the poor healing. And if you place the cesarean section uterine incision high, then again it makes the not a very good approximation of the uterine edge and affect the wound healing and the weak wound scar. So timing and the uterine incision, a place of uterine incision is very, very important, so that and what we say that when we are taking the discharge ticket, we are giving the discharge ticket, we say very sharply that this is indication. I want to emphasize that in the discharge slip you like that it was elective or it was emergency or what was the timing of cesarean section, so that in the subsequent pregnancy or in the subsequent follow-up, we know that at what time the cesarean section was done and in what way. So this is very, very important. It is like a very memorable photo with Dr. Atul Guade at Brazil in the last FIGO conference when we exchange our book. And I say to everyone that we must read beyond our textbook the books which has been written by the doctors, because actually these books open up our mind to ourselves. How the surgeon mind thinks when we are 24 hours busy or we are having less, what we are doing and what is happening in our mind when you are performing surgery. It is something seeing ourselves not from the eyes of patient but from our own eyes. Why there is a problem for standardization of cesarean section technique? Because we are having forest for tree. So many research papers are there that every person who do cesarean section find that what I am doing is okay, it is very good. And there has been the great need felt for the standardization of cesarean section technique, because from every junior to the most senior person are performing cesarean section, and everybody is doing their own way. And this standardization will help us in collecting the data from our evidence, from our research paper, and it will give the one message that this is the standard technique, of course, with the flexibility whenever it is needed. So we have to be very, very strong in teaching the trainer. We have a wonderful teacher. Important thing, it is not that the third year teach second year and second year teach first year. It should always be a controlled teaching. So these are the basic steps, right from my own book, Caesarean Delivery. These are the basic steps. And I will say what these papers says. So transverse incision is good. Blunt subcutaneous and fascia expansion, no sharp dissection, blunt peritoneal entry. Bladder flap development, usually it is recommended. Some say that it is omit, but it is only in certain situations. The uterine incision, sharp 2 to 3 centimeter transverse uterine incision, blunt entry, and the cephaloid colon expansion. Placenta removal is not recommended manually, no intrauterine wiping, no routine cervical dilatation. Uterine externalization is recommended because it adds to safety. It adds to the check of the uterine tone. It adds to the any hematoma forming posteriorly or some way. So uterine externalization is recommended as a standard technique. And the double layer non-locking suture, no irrigation, omit visceral parietal closure, omit rectus muscle approximation, omit routine glove change, rectus sheath continuous closure, subcutaneous either stapler or the subcuticular stitch. So what I emphasize that the externalization is a safer in all setting and it does not add to the time. So the important thing is then after incision is the repair, and I wish to emphasize that all over data says 2-layer repair, non-locking suture gives you the best wound. So double layer non-locking suture give you the best approximation, higher residual myometrial thickness, and the less incidence of the scar niche defect and the isthmosede. These are all new papers which actually endorse it. A strong myometrial scar with the proper anatomical approximation without tissue strangulation minimize the risk of niches and subsequent all plethora of the complication. No locking suture, no very tight second layer suture, which can lead to ischemic necrosis. Principle of basic good surgery, we have to remember good hemostasis, no tissue ischemia, devascularization, unnecessary tissue manipulation out of our security. That has to be not to be there in cesarean section. These are few new technique, that is the modification of Misclave technique, which shows that don't follow neither Fan Steele nor Joel Cohen. You just follow the natural skin crease of the woman. According to size, you extend size of the fetal head, you extend the incision, and closure of done using 2 continuous suture, which are then knotted together, which result in a short time double layer closure, and it result into the short operative time, minimal blood loss, and the shorter stay. So these are few images. These are not standard with the things which the few people are planning. They give that it gives the better myometrial scar. This is the technique which shows you give that 2 loop, that is caudal to cephalad, and you tight it, and it gives you a very good approximation. So few people who are in the teaching medical college, they can try it. So finally, surgeons believe in the curious egalitarian. We believe in practice. We don't believe in something God-given talent. It is a hard work, your experience, your humbling experience every day. So cesarean scar niche is an entity. It is a bed of all placenta accreta spectrum, which we are really, really worried about. So primary, secondary prevention, good timing, good antibiotic prophylaxis, good cesarean protocol, and standardization of the cesarean section technique is the thing. With this, I seek everybody's vote and full-hearted support for my forthcoming election. This is the time that what we say, the world has become too complex for simple answers. Actually, it is not so. Always the God has made, nature has made that all problems if we do it with the commitment and conviction, we find our answers very simply. So this is my QR code. Anybody can scan, log into my all clinical uptake and all my YouTube videos and the interviews what we had just now with the Dr. VP Pally, wonderful interview with Hema Devakar, Dr. Kamini Rao, so that we can really know how we can go ahead with the strongest professional association, fellowship, and organization. So once again, thank you for being together. Thank you for active listening. And I appeal to vote and support for my Foxy presidential candidature so that we can really work together for our fellow human being, fellow country person, and the fellow obstetrician and gynecologist. Thank you very much once again.
Thank you, madam, for your very informative and clear messaging. We all wish and pray for your grand success in the coming Foxy election. Thank you so much. And I request Dr. Ashraf and Dr. Shweta Patil to give their concluding remarks.
Good evening, everybody. This is Dr. Ashraf. Warm regards from Ballari, Karnataka. Madam has given an excellent talk on the proper techniques. The takeaway from this talk is prophylactic use of antibiotics should be minutes to 60 minutes. And then there is no doubt double layer closure is always better than single layer closure. And one more important thing, especially for beginners or postgraduates, is exterioration of the uterus will lessen the complications, especially hematomas, which can be missed sometimes when the broad ligament hematomas can be missed if they have not exteriorized and seen it properly. Madam has cleared almost all the doubts, and she has with evidence she has given the proper techniques to do C-section. I wish Madam all the best for her presidential election. Shweta, Madam.
Dr.
Good evening,
Shweta.
ma'am. Yes, ma'am. Good evening, ma'am. Ma'am, it was an excellent presentation. Thank you so much for inviting me as a chairperson. Me being an infertility consultant, obviously I would not give my expert comments on that because ma'am have already covered the topic so well. Anyway, congratulations, ma'am, and all the best.
Dr. Anupma Sundar, have you?
Yeah,
For
it
your
was an
conclusion.
excellent lecture, ma'am. Really enjoyed, and so many small takeaway points you have mentioned, especially in the discharge summary, whether this patient had an elective or an emergency section, because the patient may go next time elsewhere and we really don't know what kind of cesarean she had. So I really like that point that you have mentioned, and so many takeaway points, ma'am. So it was really interesting. Thank you, and all the best for your election.
Thank you very much.
Thank you. Thanks a lot.
Thank you very much. Now it's time for the next session, and it contains a talk on indications of cesarean section with a special reference to Robson's criteria. And the speaker is Dr. Manon Mani. To grace the occasion, our chairpersons are Dr. Shashikala Karal. She is professor and unit chief of St. John's Medical College Hospital, Bangalore. She is a life member of Foxy and has many publications in national and international journals. And she has received state award for conduction of highest number of HIV positive deliveries for 2020. Welcome, madam. Then Dr. Jyoti GS. She is professor and chief at Ramaiah Medical College and Hospital, Bengaluru. She is member of Food, Drug and Medico-Surgical Equipment and Gynae Oncology Committee. She's a lead assessor of Manyata project. She's a lead resource person and expert for the Parivartan project of contraception. He is a TOT trainer for PPIUCD, project of Foxy and Figo, and a master trainer for Dhira. Welcome, ma'am. Then Dr. Sumaya Firdaus Patel. He is a medical director and consultant of City Hospital, Belgavi. She is the president of Belgavi Society, and she is a joint secretary of IMS Belgavi Society. Welcome, ma'am. I request Dr. Shashikala to please introduce the speaker, Dr. Manon Mani.
Good evening, everyone. I'm very happy to be a part of this CME, and it's going on very well. And at the outset, I thank organizers for giving me this opportunity. Without wasting time, I introduce Dr. Manoharmani. Madam is she's talking on the indications of cesarean sections, specially referred to Robson's criteria. Madam is a professor and HOD in obstetric and gynecology. She's working in a Coimbatore Medical College, and Hospital, Tamil Nadu. And Madam is a as an undergraduate, she has a best. She got a award for best outgoing students, and she had a position like president of board of specialty faculties of obstetrics and gynecology, MGR Medical University, Tamil Nadu. And Madam is appointed as from the National Medical Board of Examination as appointed as assessor, subject expert, and a PG examiner. And she is an expert peer reviewer for a GCPR on updates in managing PCOS in women by Foxy. And Madam has the Best Doctor Award in 2019 from the Tamil Nadu state, and also she is recognized as received special award from District Collector in 2021. Presently, she is working as a COG's president, Coimbatore Obstetric and Society president 2022-2024, and she is person Yuva Foxy 2019, and she has many publications of national and international publications, and she has a special interest in high risk obstetrics. So over to ma'am.
Thank you. Thank you. Thank you for the nice introduction. Shall I share my screen? Outside, I would like to thank Sadhana Madam and the organizing team of this webinar for giving me this opportunity. So, my topic is on indications for cesarean section in special reference to 1 minute. It's special reference to this one. Sorry, I got held up in a government program on function, so that's why. One minute. Am I slides seen?
No, ma'am.
No. 1 minute, 1 minute. I think it is me. I'll do one thing.
Ma'am, please click on share screen, ma'am.
Yeah. Yeah, share screen, I have clicked on, and there is my screen I will share.
Ma'am, at first, please
Yeah,
open the
actually,
PPT, ma'am, and then start sharing the screen, ma'am.
PowerPoint, I no. So I'll do one thing. I'll switch over the camera slide side.
Okay, ma'am.
Because some problem with net connection, so it is there in my system. I'll just put it on and shall I show it and talk?
Yeah, now it's showing, yeah.
No, it's not. It must be the slide share. Huh? No, this way we can.
Pardon? No, sorry.
Saiti, you help.
No, it is there in the system.
Ma'am, or else can you mail it to me, ma'am, so that I will share on
Send
behalf.
mail to Saiti. Can I WhatsApp to you? Shall I WhatsApp to you?
Yes, ma'am. I will share my number.
Saiti, just tell your number to madam.
Yes, ma'am.
I think you will call me, right? It is.
Ma'am, I have shared my number in chat box to you, ma'am. Please check.
Okay. Sorry for that problem with me.
because the net connection was not good over here. That is the issue. So this is 9848067955, is it?
No, madam, that's my number.
Okay.
Sahiti's number has been shared in the chat box. Just send her, she'll share the screen.
Madam, please, if you don't mind, shall I have the number? Please just tell me, no, because it is.
Sahiti, just tell your number.
Yeah.
Yeah, you can see it on the screen.
9600
Pardon? Number, madam?
9600 757615.
757615. Yeah. I have sent, madam. I think it has reached.
Sahiti, can you just check and share?
Yes, ma'am. I'm downloading the slides, ma'am. 1 minute.
Yeah, it has come. Sorry for the problem. I'm extremely sorry. Actually, I'll just start by the time she shares. So the indications of cesarean section in special reference to Robson's criteria is the topic given to me. So actually, I would like to thank Sadhana ma'am for giving me this topic, so that I could again go research what has been there in the regarding the Robson's criteria and what I have been doing, what is the latest recommendations and all our guidelines. As the slides come, please. So the next. So the indications, so we should know what are the need for this talk about Robson's criteria and cesarean sections. I put my talk in the way of cesarean section indications, what are being the traditional and what is the Robson's change in the Robson's criteria. Have you received my slides?
Yes, ma'am. It's downloading, ma'am. Just one. Yes, ma'am. I have received your slides, ma'am. Just 1 second, ma'am. It's downloading.
Okay, okay. So to start with, I'll put give a scenario. How do we classify for a regular indication? How do we classify for the Robson's? It is a woman in a 4th pregnancy with previous miscarriages at 8 weeks, 12 weeks, and 14 weeks, who had been admitted at 38 weeks in spontaneous labor with a single cephalic fetus. So this patient should be taken up for cesarean section. How do we classify her? Suppose if you are classifying as per routine, we'll be saying that she is a recurrent pregnancy loss and in labors, and if she goes in for cesarean section, we say that it is because of fetal distress. We put it as RPL with fetal distress, depending upon, or if she has not gone in for labor. And the previous slide, previous one. Yeah. So this is how you place my contents. Next slide. So this is scenario. So how do we put them in the regular case as well as in Robson's criteria? Where do we place her? Next. Next slide. So this is about what WHO said in 1985. They said 10 to 15% of cesarean section should be done for the better maternal and perinatal morbidity and mortality. But then so much of hue and cry from 1985 for the past 40 years that so many cesareans have been done. Private hospitals doing more and government hospitals doing less, and all the countries have more number of cesarean. So went on for so many years, but now in April 2015, WHO had given a statement on cesarean section that every effort should be made to provide a cesarean section to women in need, rather than striving to achieve a specific rate. It is a major announcement from WHO. So this has been changed from 1993 statement of WHO. Next slide, please. So this is a picture of WHO projected picture, wherein it showed that if you could see that yellow area, Tamil Nadu, India is there. So we will be in the range of going in for 25 to 30% of cesarean section. If you could see in the near blue, the India has been shown in the range of 25 to 30. Next slide, please. Next. So this is the latest release NHS survey. Next. Next. So if you could see that box, no, the previous. If you could see in the previous box, births delivered by cesarean section was in 2019-21, it was 21%. It has been come up to 21% with the urban area showing 32 and rural area showing 17. Wherein it was in 15-16, it was 17.2. This is the latest NFH survey of the Government of India. Next. So what do? We recap for a few indications of elective and emergency cesarean section. Next. This everybody knows. This is we are classifying based upon the timing of cesarean section as elective or emergency. Depending upon emergency, we say from category 1 to 4, and depending upon the type, it is lower segment or classical cesarean section. Next. 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 Yeah. So indications, traditionally we have been saying that elective, it is maternal indications or fetal indications, wherein there is patient is not in labor. Where it's going to be emergency, it is a maternal fetal indications where patient is in labor. There is a new entity called as CDMR, that is cesarean delivery on maternal request. So these are all the indications for elective cesarean, starting from maternal to fetal. All of you know, it is a previous section, either it is a 1 cesarean, it is a relative indication, 2 and more, it is absolute indication, previous uterine surgeries, placenta, complete placenta previa, so on and so forth, and as well fetal IUGR with the Doppler changes, non-cephalic first twin, presentations and macrosomia and previous. So next, going in for emergency cesarean section. Next, emergency cesarean section, majority is patient in labor from dystocia to failure to progress, abnormal uterine action, disorders, Harass disorders, abruption and placental abruption, failed induction, non-status. Next, please. Next slide. Yeah. So as per the NICE guideline updated as latest as 21st June of 2023, as all of you know, within 30 minutes, it is a urgent cesarean in rupture, major placental abruption with bleeding, cord collapse, hypoxia and persistent bradycardia. So we know within 75 minutes, it is second category, where it is maternal fetal compromise, which is not immediately life-threatening. 3 and 4, as all of you know, it is more or less semi-elective and elective. Next slide. So with this background indications for what have been going on so far, now there is a 10 group or option classification. So this is introduced way back in 2001 by Michael Robson. So it had taken nearly 20 years for us to follow this, because now Government of India with our I3 case sheets and for auditing the cesarean sections, we have been following this Robson's classification. All medical colleges have started using this. So this as a clinically relevant framework to assess the differences in cesarean section rate. It serves as the initial structure wherein other epidemiological variables are added so that we can analyze. Next slide. So WHO implemented in 2015 following systematic review that identified 27 different systems to classify cesarean. Classifications looked at who based on women, why indication based and when urgency based, as well as where, how and by who a cesarean section was performed. So it is analyzed from 2011. Next. Next please. Analyzed, and they have review included 75 publications from 31 countries that reported on the use of Robson classification from 2000 to 2013. So 13 years of usage analyzed, and they stated that it is a simple, reproducible, robust, clinically relevant classification system. Next slide. Next slide. So finally, in October 2014, WHO in a panel of experts, and they said use of Robson classification at facility level in order to establish a common point of time of the meta-perinatal data, and over time, and it could be used between the facilities also to compare. So they have decided to adopt the Robson classification as the official name for this classification. Next slide, please. Next slide. Next. So Robson classification is for deliver at a specific setting like maternity hospital or a region. It is not only for the women who deliver by cesarean. It is complete parental class. Once the woman is admitted, to classify them to which groups it belongs to. So officially endorsed use from 2015. For the past 8 years, it is officially endorsed. Next slide. Next. So Robson, what can it do for us? It identifies, analyzes the group of women which contributes most to the cesarean section as well as the overall cesarean section rate. So of the 10 groups, we can analyze which is more important, compare the practice in this group of women, and we can compare it to other units also, and assess the effectiveness of strategies or intervention targeting the use of cesarean section. That is the single most use of the Robson's classification, and as well, it assess the quality of care and management practices, and we can analyze even the quality of the data collected by the staff and importance of the data and interpretation of its uses. So this is what the use of the Robson classification. Next slide. So this is the pictographic Robson classification. If you could see the group 1, it is a nulliparous women with a single cephalic. This is by itself explanatory. If you could see the 2 lines like a wave, it shows that the patient is in labor. So if there is no, then you can see the baby inside the women's picture. It is the cephalic presentation, single baby with a pain. So it shows patient is in labor, spontaneous labor. Group 2 is, you could see the same picture but without the mother without the wave-like form, which is not, patient is not in labor. And group 3 is, it is a multiple pregnant, multiparous. You could see a baby by the side of the pictogram. Again, the baby is cephalic. And group that is in labor, patient is in labor. Group 4 is multiparous, single cephalic more than 37 weeks, and patient not in labor. Then group 5 is, if the C shows it is a previous cesarean section. Again, it is all multiparous with one previous cesarean. And group 6 is all nulliparous women with a breech. So again, the fetus baby is shown in the breech position. And group 7 is the multiparous women with a single breech. And group 8 is a twin pregnancy, irrespective of the parity. And group 9 is transverse live. And group 10 is less than 37 weeks. It's a preterm. So as the picture shows, this is the 10 groups of Robson's classification. But again, after some years of using, some analysis is being done and some subdivisions have been added. So if you take the subdivision to nulliparous women without pain, 2A shows that labor is induced. 2B is patient is taken up for cesarean without labor induction. Same way, group 4, 3, 1, remember 1 and 3 are patients already in labor, wherein 2 and 4 are not in labor. So subdivision 4 is again given a subclassification as 4A is labor induced, 4B is pre-labor cesarean section. Again, it is a multiparous more than 37 weeks. And subdivision of group 5. Again, if she is 5A is 1 previous cesarean and 5B is 2 or more previous cesarean section. So from Robson classification, 10 classification system for 2, 4 and 5, there are two subdivisions. This is what we need to remember and write, document. So in principle, since these variables are routinely collected, it can be used in the clinical management of women admitted in for delivery. And we can obtain this from each woman's record. So what are the variables? If you can see, it is a parity, whether she is nulli or multipara, previous cesarean section, yes or no, whether the patient is an onset of labor, spontaneous or induced, number of fetuses, single or multiple, gestational age, preterm, that is less than 37, more than 37, and lie in presentation, cephalic, breech or transversal age. So these are the variables which can be commonly, anybody can, even our BHNs and nursing can get these variables. And this is the labor room register also should be used as per the Lakshya guidelines. So all this data we can enter it into your patch reset register. This is all your team as well as whether the patient is can document, and we can put it in the Robson's classification system and we can analyze. So this is how we have to use it. Flow chart. You start here as a multiple pregnancy, straight away she goes to 8. Whether she is labor, transverse or oblique lie, it goes to 9. And breech pregnancy, if she is multi, it is 7. If she is primary, it goes to 6. And gestation age of 37 weeks, straight away it is going to 10. So we get any data based upon the presentation and position, and primary or multi. These things are easy to remember. And wherein if the multiparous woman, if there's a previous cesarean, all cases go to 5. And if she is labor induced cesarean section before labor, she is 4. And the primary without pain 1, with the pain 1, and without pain induced is 2. So this is how we can classify our patients for interruption once they are getting admitted. Next slide, please. So this is another way of having a tableau column. We can have it in a labor wall so that everybody can see and put all the classifications depending upon primary, multi, as well as presentations and positions. Next. Next, please. So this is the manual. So if you could, actually I had been presenting a very bird's eye view of the Robson's classification. So the WHO had come out with the manual, implementation manual. You can go and access it online. So it shows how and how we have to go and write the document in our case sheets. Next slide, please. Next slide. Again, WHO had got a platform for Robson's classification. In this platform, again, we can go for the how we have to go for the Robson's classification, how to enter the data, and how to optimize the cesarean section based upon the data available. And if there is any doubt, we have to put it in a table or column, and we have to analyze for each group. Group 1, what is the contribution for cesarean section, and group 2, how we can prevent that. And there is a YouTube also. It has been released in 2021. So we can use this YouTube, again teaches us how we have to enter in the page sheets and how we have to audit it. Entering alone is not sufficient. We have to audit and see to that which group is more contributory to the cesarean sections, so that we can do some improvement and bring out the better perinatal outcomes, as well as no morbidity and mortality. So that I would like to say that being a good doctor, health provider is like being a good goalkeeper. No matter how many goals we save, people remember only the one that we missed. So always maternity, next slide please. Always maternity, how many deliveries, how many babies, how many mothers we save. But one mortality will bring us doom, as well both the practice as well as the on the other sides. So with this, I would like to thank Sadhana ma'am for giving me this opportunity. Actually, I had taken up the only bird's eye view for Robson's classification. So each and everything we can go on for a single workshop. So each group, how to have the percentage of classification and what is the impact and how we have to improve. That is, we have to go through the manual and we have to implement. Here we have started implement all the 10 classifications, and end of analysis. We are having more cesareans in a previous cesarean section because way back is not being practiced to that much extent. So majority is our previous cesarean section. Group 5 is going for major indications for cesarean. But another next contributory factor, teaching hospitalists, group 1, patient going in, coming with any meconium stain or like that, sometimes you're taking. The next major contributor is primary parous women, group 2, labor induced. So many times with the fetal distress. So the fetal distress point has not been taken up into the Robson's classification. As Madam already said in our opening talk, that has got so many setbacks in Robson's classification. For example, fetal distress, it doesn't come anywhere in this classification. It only talks about parity and the presentation and gestational age, whether they are in labor or not. But additional things of fetal distress and all those things have to be incorporated, and we have to analyze in such a way that we improve our standards. So I thank you all for the patient hearing. I am extremely sorry for the initial glitches into my login. Thank you, madam.
Thank you, ma'am, for your informative talk. Now I request the chairpersons to give their concluding remarks.
Good evening. Madam has nicely told about the Robson's classification, the pros and cons. But one thing I would like to tell is, I am a Manyata assessor from the past 3 to 4 years. From 2020, I've been assessing so many institutions of Manyata. This Robson's classification is a vital part of the standard 16 of the Manyata, and I have seen that it has raised the awareness amidst the paramedics, which is very important. And so nicely, when we give a scenario, they nicely tell that this belongs to this group. This is one wonderful contribution which I have seen through Manyata for the awareness in the paramedics. And they are aware about that, how to reduce that. They become sensitized. Like for group 5, many numbers are there as for previous section rates, how to audit. Everything has been nicely brought out, and it has raised the awareness amidst the paramedics by using this Robson's classification.
To close this one more this madam, actually I said a case scenario to start with. Actually, we write is Gravida 3, Gravida 4 and RPL, but as per Robson's, it goes to the group 1. She is nulliparous, she is not delivery.
That's why we give scenarios like this. We give scenarios like this to the paramedics, and they classify it.
Because everybody should need to know, we have to classify and put our cases as per Robson.
Auditing also, even auditing awareness.
This is also explained that it also helps to do the auditing and compare the cesarean section rates in the other hospitals actually. What is the it's like indication, common indications and all we can come to know, and we can reduce the rates also.
Yeah, but large systemic audits, when you have to compare from one hospital, other hospital, maybe we may have some lacunae in some factors which needs to be audited. Some fetal factors, maternal factors could be there, but it is still welcome.
Madam, actually in government of Tamil Nadu, we are going for cesarean section audit with this Robson's 10 class, Robson's classification. So it is easy for comparison among all the hospitals of our state. So it has been, all our PGs are getting trained, and we are also getting trained to document per the Robson classification for cesarean section audit.
We're
so
giving
once we
thesis.
start entering only, we have all this doubts, where to put this, where to put 20-30 cases, then we will be used to that. So it will be easy to put them, and we have to classify and actually do the audit and put the percentage for each and everything. That itself we can talk for 1 hour, how to go and each group to use in that is the data is correct. If it is accepting, if you are wrongly entering everything, we can go through that. Thank you for the opportunity.
Thank you so much, madam. Now I hand it over to Dr. Shailja for the rest of the program. Thank you. Dr. Shailja, over to you.
We'll be going to session 3 on post-cesarean care and complications, where Dr. Papa Dasari will be speaking. Our chairpersons for this session are Dr. Shraddha Shetty from Bangalore, who is the professor and head in Department of OBG, Kasturba Medical College, Bangalore. She is an undergraduate and postgraduate teacher, has published articles in national and international journals, is a member of MOGS, AMC and IMA Mangalore. Her areas of specific interest being high-risk pregnancy. And Dr. Swapna Brijesh, who is the Secretary, Mangalore OBG Society. I hand over to the chairpersons for conducting the third session.
Now I would like to give introduction regarding our Madam Dr. Papa Dasari. her CV, even one page is also not enough to describe
No,
about
you
her
just
CV.
skip it because time is running.
Okay,
And,
fine, ma'am.
yeah.
Okay, fine. Please go ahead, ma'am.
I'll share.
Okay.
I'll share my slides.
Okay, sure, ma'am.
Yes, ma'am.
Because my audio is a little unstable.
Okay, ma'am.
Okay.
Please go ahead, ma'am.
Okay. Where is my slide bar? Can you see my slides?
Yes, ma'am, I can see.
Okay. Good evening and thanks for Dr. Sadhana Gupta and Dr. Saileja Madam to have given me this opportunity. And Dr. Sadhana Ma'am has already told, she has given an excellent talk and she also covered some of the complications of cesarean section. We just directly go into the post-operative care. So there are two topics here. One is the post-operative care. Second one is the post-op complications. Is that cesarean section complication? I think intraoperative complications may be discussed in the panel discussion also. I go for post-operative complications. As all of you know that cesarean section is the most common surgery and
Excuse me, madam, can you please make it slideshow?
I made it slideshow.
No, madam, it's not visible as slideshow.
Make it full screen.
Yeah, full screen. I made.
It's not full screen, madam.
Ma'am, in the right side, lower one, there is an entity called slideshow. Please click into that, ma'am. Right side, lower part.
Lower part, it is gone
right
up
side.
for me. No slide. I'm not able to see.
Ma'am, or else kindly reshare it, ma'am. Stop share and then reshare it.
Okay, this is one beer glass sort of thing, here in the near the 6% near to the beer glass sort. If you click that will come. This is one beer glass, so.
Just come here. They are not able to see slideshow. Just see.
Or else at the top of the screen you have, no madam, apart from home, insert, design, animations, next you have slideshow.
I don't know,
At the
it's
top
not
of the
coming
screen.
slideshow.
Ma'am, you
Just
can
make
stop
it slideshow.
sharing and share it again, ma'am. You
Okay.
can do that.
Okay. Share. Yeah. Sure. Can you see now?
Yes.
Yeah, it's visible, ma'am.
Yeah, madam, it is slideshow.
Slideshow?
Yes, it's visible, ma'am.
Okay, thanks. It's not moving now.
Click on the screen once, ma'am, then it will start. Yeah, to the left corner, you can see the.
It's moving.
Okay, thank you. Okay, post-operative care, as all of you know that it differs is in the immediate post-op period within 12 hours, 24 hours, and after 24 hours till discharge. And during this time, we have to monitor the patient carefully to diagnose the complications of cesarean section. So the monitoring depends on the type of case, whether there were any intraoperative complications, whether there are no complications intraoperatively and preoperatively. Continuous one-to-one observation is necessary when the cesarean was done under spinal or epidural anesthesia till she is hemodynamically stable. And this initial monitoring is usually done by the anesthetist in the recovery room. And later, we have to monitor her at least for 12 hours in the post-operative ward. And when the anesthetists say that there are no complications due to spinal anesthesia or epidural anesthesia, or they may stop continuous epidural anesthesia, and then we can shift her to the ward for routine observations according to the local protocols. So if she is at increased risk of respiratory depression, example raised BMI, or she has a history of obstructive sleep apnea, we have to do continuous pulse oximetry monitoring and hourly monitoring of respiratory rate, heart rate, blood pressure, and temperature. And we have to give adequate sedation, because this pain also can give rise to respiratory symptoms. And we need to pay particular attention to these symptoms, such as cough and shortness of breath, and also the leg symptoms, painful swollen cough. Even within the first 48 hours, they can develop a deep vein thrombosis or pulmonary embolism if the patient is not put on prophylactic thromboprophylaxis. Fluid management, standard management is we give crystalloids 75 to 100 ml per hour till the bowel sounds return. This is the standard which we have been following. But now recently errors have come, which I am just going to talk later. And we need to add oxytocin to maintain the contraction of the uterus. And fluid restriction in heart disease and pulmonary edema and renal disorders. Fluid and blood administration in women we have lost. We have had PPH intraoperatively is important. And we also need to maintain the input-output chart. Pain management, if the patient had general anesthesia, one may go for intravenous patient-controlled analgesia, which usually morphine is used. If it is less severe, we can give morphine sulfate orally, or injection paracetamol, or combination of a paracetamol and dihydrocodeine. But this combination usually causes neonatal depression. So this is not the protocol in our hospital. Usually, we give injection paracetamol 1 gram IV 12-hourly or 8-hourly, depending on the patient's needs. And vaginal bleeding after CS within the first 12 hours or immediately, there may be PPH. So that is the reason where we continuously monitor, one-to-one monitoring in the recovery room. So sometimes the patient may bleed immediately after cesarean because of atonicity. She may develop later after the cesarean wound is closed, or sometimes the patient may be in hypotensive anesthesia, and then the angle, or there may be some bleeding in the angles, which may reveal as a vaginal bleeding. So if there is irregular bleeding after 24 hours, we need to consider first endometritis rather than retained products of conception, because we assume that we have removed the placenta during cesarean section. We remove the placenta completely without leaving any membranes, because some institutes routinely thoroughly examine the uterine cavity before attempting the uterine closure, so that there are no placental bits and membranes. Wound care, we're removing the standard dressing 6 to 24 hours after the cesarean birth. We remove usually after 48 hours because we put an elastoplast, and we have to inspect the wound daily and clean the wound. And we have to encourage the woman for early ovulation. And also we have to plan the removal of the sutures or clips. Wound care, as per the guidelines, RCVG guidelines, the sutures are better than the staples. And also aseptic non-touch technique should be used whenever we clean the wound. Sterile saline is the one which is advocated for cleaning the wound rather than the spirit or iodine. Advise the patient that they may take their bath after 48 hours of surgery. Regarding the wound infection, so when there is no difference if you remove the dressing after 6 hours or after 24 hours, or there is no difference in infection whether the dressing is, whether different kinds of dressings are used. And you should not use any topical antimicrobial agents for primary intention. And when the wound is infected and it is gaped, we should not also put Usol and gauze, which usually is has been the practice. And this will invite more infection. And if the wound is infected, that you have to use higher antibiotics, depending upon the local resistance pattern after discussing with the microbiologist. And again, when debridement is done, we should not put a Usol gauze or Dextranomar or any enzymatic treatments, because this will cause erosion of the tissues and tissue damage. So when she is discharged home, we can discharge her as soon as she feels comfortable. She can resume the work. Maybe it is the 4th day, 5th day. It depends on each patient how soon they recover. And we have to give her medications on the discharge slip. And also we have to give her contraceptive advice. We have to mention that if you put an intrauterine copper device, that is intracaesarean copper T, we have to clearly mention that and give her advice when she should come for checkup. And also she should check the pads whether it is expulsed, because expulsion rates are high. And nutritional advice and possible complications within a month. That is, madam has already told Caesarean scar defect, Caesarean scar pregnancy. And also we have to clearly mention whether there is any indication for a repeat Caesarean section, or she can undergo TOLAC. This we have to do at the time of discharge. So coming to the ERAC, that is enhanced recovery after Caesarean section. Now it is applied. Initially it started with colorectal cancer. Now it is being applied to the Caesarean section. The concept is that there is a higher maternal satisfaction because of the early discharge. This is the only one factor based on which this ERAS has come to Caesarean section. So it has 3 arms, that is preoperative, intraoperative, and postoperative. The main thing is the patient can take oral fluids, carbohydrate rich fluids up to 2 hours of prior to anesthesia, as compared to the standard that 8 to 10 hours fasting. Intraoperatively, fluid balance and also warming. The anesthetist has to maintain the patient warming during the intraoperative period. And postoperatively, the analgesia is very, very important. And early mobilization, early removal of the catheter, and early initiation of oral fluids. This we should apply only to the patients who had uncomplicated cesarean delivery, not otherwise. So this is just to show what is to be given. We may give 500 ml of apple juice. She can take 2 hours, and can also take a painkiller. And then intraoperatively, they should have neuroaxial morphine or nausea vomiting prophylaxis. We do give metoclopramide and ondansetron or ranitidine. And intraoperatively, they should not make the patient to go into hypotension. They should use phenylephrine infusion and make sure that there is no hypotension. And post-operatively, the patients can get acetaminophen or ibuprofen or naproxen depending on the availability. And also oxycodone 5 milligram per oral. So these are the benefits, that it reduces the opioid consumption and length of stay. And prophylactic infusion is very, very important to reduce the nausea and vomiting instead of giving, and also rescue treatment of phenylephrine is very important, which is to be given 50 micrograms per minute. And use of combination therapy of non-sedating agents such as ondansetron with dexamethasone also is used in some of the institutes as per the protocol. And low dose oxytocin, that is 15 to 18 units per hour, can be given to prevent postpartum hemorrhage. or if carbitocin is there in the protocol and it is easily available, we can also use that. So maintaining the temperature perioperatively reduces the risk of post-operative infection, coagulopathy, blood loss, and also the transfusion requirement. And preoperative morbid conditions, this is the complications following cesarean sections will depend on preoperative morbid conditions, that is medical disorders, whether the patient is suffering from diabetes, heart disease, or epilepsy, and also on the surgical technique and associated procedures, whether we have done a myomectomy, cesarean myomectomy, or ovariotomy or tubectomy, and number of previous cesarean sections and prior surgeries, and also additions. And we have to clearly mention in the operative notes what are the intraoperative complications, like whether there was atony and whether they how they controlled it, whether surgical methods like B-Lynch suture or Hammond sutures are used, or uterine artery ligations are done. And also it depends on elective or emergency, and whether antibiotic prophylaxis is given timely. Madam has already mentioned we have to give, the standard is 30 minutes to 1 hour. And also the type of anesthesia influences the complications and thromboprophylaxis. So the common problems are abdominal distension that can occur 10 to 20%. And some of the documents, publications give that PPH is around 6% following cesarean section when compared to 4% following vaginal delivery. And urinary symptoms. Sometimes there may be an occult injury which may present as a hematuria in the immediate postoperative period. And vaginal bleeding. Continuous vaginal bleeding may be slow, but if the clots are forming, then we have to look whether there is any bleeder that has been left and it is presenting as a hemorrhage, postpartum hemorrhage. Wound infection is reported to be as high as 3 to 15%. And I just said about the urinary complication, stress incontinence occurs around 4%. And urinary tract injuries are 1 in 1,000 cesarean births. What information we have to give to the patients, especially the educated patients, before taking for cesarean section, along with all other counseling, what is the indication for cesarean section? We have to talk one word about the risks, that there is an increased risk of bowel obstruction and surgery for bowel obstruction, which is 2 times higher, and also later development of incisional hernia, though now with the transverse incisions, the incidence of hernia is less, and also chances of having chronic pain abdomen. All these things we have to speak. If the patient is obese and she had more than 1 cesarean delivery, the risk of all these complications are going to increase. What about the morbidity after cesarean section? It is said that there are 3 key contributors to maternal morbidity and mortality, and these are hemorrhage, surgical site infection, and venous thromboembolism. So cesarean delivery increases the risk of infection and its related morbidity to 5 to 20-fold compared to vaginal delivery. So this kind of counseling is important, especially if they request cesarean section, that is maternal request or cesarean on demand. We have to make them know this, but we have to carefully see that whether there is any indication we are missing in that particular patient for cesarean section. So denying cesarean section when indicated also increases maternal and fetal morbidity and mortality. Actually, WHO says that the incidence of cesarean section is to be there 10 to 15%, and this statement is not based on any studies. One of the studies that is published, they say that the perinatal as well as maternal mortality decreases when the cesarean section rate is around 30%. Because compared to 4 or 5 decades ago, now the cesarean section indications mostly we are doing for fetal indications. That is what is increased. The commonest indication is fetal distress, which one cannot avoid, but we have to diagnose fetal distress properly. So what are the unusual complications? So toxicity to local anesthetics like bupivacaine. We had a case which presented as convulsions, and that was misdiagnosed as eclampsia. But really, we have to think of this anesthesia complications, and we have to manage appropriately aspiration, especially when we give fundal pressure while delivering the baby in emergency situation. There can be aspirations. And if you don't give a prophylactic magnesium sulfate in case of severe preeclampsia, then patient may develop convulsions. This is also one of the common situations we are finding in our institute. She may develop postpartum eclampsia in the immediate postoperative period. And we also had some cases of rectus sheath hematoma, because this is a muscle splitting incision. Some of the veins that will get torn in the rectus sheath, they may present as a hematoma, sometimes as an intraperitoneal hemorrhage also. So we should be well prepared to deal with postpartum hemorrhage in cesarean section. That is also 2 to 4-fold higher when compared to vaginal delivery. But the uterus is in our hands, but we can manage better during cesarean section, arresting the bleeding rather than following the vaginal delivery. And we did have some cases of hematomas in utrovesical fold, which we should really look carefully before suturing the, before finally closing the abdomen. And this pseudoaneurysm also, has Madam told, that secondary PPH. And severe sepsis and septic shock, the incidence is less than 1%, but we have to be prepared to manage that also. Postpartum hemorrhage care bundles are given recently in 2020 by WHO. As soon as we diagnose the PPH, we have to activate the PPH bundle. And the first hour, it is very important that we should give adequate fluids. After immediately starting the uterotronics, you have given prophylactic, but we have to continue this after surgery also. And sublingual misoprostol and injection tranexamic acid also is there in the WHO PPH bundle. And you have to be prepared to give the blood and blood products. If the shock is massive, like and the bleeding is continuing, then you may have to initiate the massive blood transfusion protocol. I just present some of the rare complications. This is abdominal compartment syndrome after cesarean section. If the intra-abdominal pressure rises more than 25 mmHg or bladder pressure is more than 12 millimeters of mercury, it affects the perfusion of all the abdominal organs, including the intestines, and cause ischemia. So what are the reasons? Whenever there are additions, it may form intestinal obstructions, or when you close the abdomen very tightly, this also predisposes. There may be ascites in cases of HELLP syndrome, and also paralytic ileus if you don't act on it, treat it immediately. It can give rise to this abdominal compartment syndrome. And decompression technique should be used. And the pressure, whenever the pressure was more than 15 mm mercury, usually the bladder pressure is measured rather than the intra-abdominal pressure. So this due to cesarean section is a rare event, but it can happen after any surgery. This is a major cause for mortality. Mortality is as high as 50% is reported in literature if you are not decompressing early within 24 hours. This is another rare condition, that is Ogilvie's syndrome. The incidence is 100 cases per 10,000 patients per year. So this also called acute colonic pseudo obstruction with bowel rupture. Here only the large intestine is affected, that gets dilated. And here also decompression or surgery has to be done in some cases to prevent intestinal perforation. Mortality has been reported following this condition. And other complication, rare complications we had were uterocutaneous fistula. This is a picture on the left side, the uterine cavity communicating to the skin. And this is a MRI you may require sometimes to diagnose this. Management, excision of the tract and closure. And urinary incontinence and cyclic hematuria, where you can find, these are the very rare things nowadays. Earlier it used to be very common. So the bladder is not retracted well, and some of the bladder fibers may be included when suturing the uterus. And these are the retained products of conception even after cesarean section. They present as a secondary postpartum hemorrhage. The second picture shows hysteroscopic picture. We can remove hysteroscopically when it is adherent. And delayed uterine necrosis. This is the patient that is reported. They thought the uterine, the abdominal wound is not healing. But when they did the debridement, they found that they're removing the uterine muscle. This is necrosed. So this patient went in for hysterectomy because of the gangrene. This is one of the patients which I have managed. This is following a B-Lynch suture. You can see that how necrosed the uterus is white, and this is the gutter of the suture. This is after 10 days of the procedure. We have reopened this, and you can see this is our necrosed uterus looks like, and this is perfused. After removing the suture, we can see nicely the blood flow is getting on the other part of the uterus also, it is getting restored. So we didn't go in for hysterectomy. We just gave wash and closed the uterus, and ultimately she has recovered and also conceived after 3 years. So septic shock, therapeutic antibiotics, if you forget to give and timely, you may find a patient going in for septic shock within 12 hours. Goal directed therapy, sepsis bundle has to be initiated. First 1 hour fluid challenge, infuse 1 liter per hour. And after that, you should start on intravenous broad spectrum antibiotics all within 1 hour, and early correction of the metabolic acidosis. So prevention of morbidity and mortality is very important. Preventing wound infection. There are 4 preoperative and perioperative interventions. Like recent studies have proved that vaginal cleansing can help in decreasing the sepsis after cesarean section, and antibiotic prophylaxis, and also maintaining hypothermia. Chlorohexidine alcohol is preferred than povidone iodine. And about this hair removal, also clipping is better than shaving. And whenever antibiotics are given, we have to use weight-based dosing rather than just giving everybody the same dose. If the patient is allergic to ampicillin, penicillin group, you should use clindamycin with an aminoglycoside. And whenever the surgery is prolonged, like 3 to 4 hours, or obese women, or there is a PPH at cesarean section, you should give additional dose of antibiotics. Preventing wound infection, active and passive warming during surgery is very important. And we should think of post-operative endometritis whenever there is post-operative pyrexia, and use antibiotics, because this group A streptococci and group B streptococci, these are very virulent, and the patient can go in for severe sepsis and septic shock and septicemia and maternal death. So it is very important which kind of antibiotics you choose in case of postoperative pyrexia. And venous thromboembolism is a 10% of pregnancy, and the risk increases to 80-fold. And so we have to identify the women who are at a higher risk for thromboembolism and give them prophylaxis. Once VTE develops, we have to treat it properly. Fortunately, VTE is less common in India than at Western countries. Thank you. And we should perform cesarean only to save maternal and fetal life, and certainly not on demand. I didn't cover the cesarean scar defect because madam has extensively covered the cesarean scar defect now, which is becoming more and more common, and also placenta accreta syndrome. Thank you.
Thank you, Dr. Papadasari, for that exhaustive lecture on post-cesarean care and complications. We have a question. Should we remove the placental membranes completely before uterine closure? The doctor who is asking this question says she had a patient who had postpartum bleeding per vaginum on and off in the second and third week. Ultrasound showed retained products with increased Doppler. She did suction evacuation with antibiotic coverage. What should be the ideal management in such cases?
So we remove the placental bits and membranes. In fact, we can take a sponge holder with a gauze and gently, not pushing, with gentle movement, we can wipe the uterine cavity. That will bring out all the membrane. Sometimes membranes are adherent. So it is essential that we examine the placenta as we examine after vaginal delivery, that any small cotyledons and membranes are left behind.
There is a question from Dr. Bharti Rajshekar, our expert for the panel today. What could be the reason for chronic sinus in patients after 3 to 6 months post-cesarean section? Could it be atypical mycobacterial infection?
Mycobacterial?
Yes, ma'am.
Tuberculosis?
Yes, ma'am. Dr. Bharti Rajshekar is asking this question.
Yes, one
Bharti, madam, are you there?
Yeah, I had a clinical experience of doing one patient last year. The patient has been coming past 2-3 years, and people are treating her as a stitch sinus. They have explored 2-3 times. And then when I opened that scar excision, we did. Where is the proline suture? Is it deep inside? Then I found that the track going into the uterine cavity. I don't have any experience regarding the atypical mycobacteria, but if it is tuberculosis, yes, definitely we have to send this excised track for culture, pyogenic culture, as well as the tuberculosis for histopathology.
Thank you, ma'am. I would like the chairpersons to give the concluding remarks.
Thank you very much, ma'am. You have covered everything in post-operative care and complications. It was extensive and it was very informative. And there's not much of time, I think. There's nothing much from my side. Thank you very much.
Sorry if I've taken a long time.
You have covered everything. Yeah, there's nothing much to ask from our side. Yeah.
Thank you. Thanks, everybody, the organizers, Sadhana ma'am, for the opportunity. Thank you.
Thank you, Dr. Papa. It's always great to listen to you, and very, very nice compilation. And what Dr. Bharti says, actually, this chronic sinus really troubles us. And high resolution ultrasound helps a lot sometimes, because we can have the fluid collection and what is the track going on. And rightly says, sometimes the tuberculosis and sometimes like what is a foreign body material, which is they are always irking. So we have to excise. So this sinus is really, and one case, it is not like it is a long ago I started just practice. I have one case that is the patient coming with the always sometimes the feces per vagina. So everybody thought that she is psycho and nothing. So I was very young. So we did all the swab and said, no, she is right that she is passing feces per vagina. When we opened, and it was in a corrugated drain, like around 3 years ago in medical college, that at that time that it was a common like 80s, and that corrugated drain between the uterus, and it was a uterocolic fistula. So that paper also I got published in Jogi, and that was something that it can happen, and we have to be very careful about all these complaints. And we took on like the ureteric injury, it is coming with fistula, and say no, it is discharge, but it is urinary. So inadvertent injury, what we will be discussing into the panel discussion. So this is the medical legal issues be great with the post.
And we had a case of gossipy bioma that the gauze pieces left. The patient presented after 10 years as a mass abdomen, misdiagnosed as ovarian tumor. Like These are
There's another
very, very
question,
rare.
madam. They're asking how to prevent numbness over the cesarean section scar.
We cannot prevent because obviously when we give an incision, small nerve fibers will get cut. Only thing is, I would say that don't use cautery much. That is one of the things that you should not use. And reassure the patient, she may feel some numbness, it will come back after healing. It may take 6 months, or you can give her some neurovitamins for faster recovery.
Thank you so much, madam. We'll go ahead with the panel discussion. Sahiti, can we have the slides? Dr. Bharti Rajshekar CV, please, our expert today for the panel discussion. Can we have the CV of Dr. Bharti Rajshekar? Dr. Bharti Rajshekar is the State Vice President for KPMEA and the Indian Red Cross Hassan Director. She has been the IMA State past Vice President and past President and Secretary for Hassan. And she is the PCPNDT committee member for, has been PCPNDT committee member for Hassan.
You
In
can
Foxy,
just
she has
skip it, I
done
think.
Food Medical Equipment and Drug Committee member, as Preventive Oncology Committee member, PAC Committee, South Zone Coordinator, has been the Foxy Dhira Program Trainer and RAC Program Trainer, has been the Executive Member HPT and HSSC. So many awards and activities to her credit. A special interest being adolescent health and high-risk pregnancy, preventive oncology, geriatric health in women, and family welfare and contraception. Can we have the slides of the panelists, please? I welcome all the panelists for this discussion on difficult situations in cesarean section. Dr. Shivakumar, who is an associate professor, Vijayanagara Institute of Medical Sciences, Ballari, and consultant Shiva Super Specialty Clinic, Ballari. Sir has won the Best Post Award in NatCon 2014 at Chennai, third prize for paper presentation and staging of cervical cancer at NatCon 2017 in Bangalore in the Second Indian Cancer Congress. He has 6 publications in oncology to his credit. He is affiliated to IMA and so many societies. He is right now the President Ballari OBGYN Society. Next slide. Dr. Manjula Patil is the Senior Consultant at Sri Vinayaka Nursing Home, Gangavati, and President Women Doctors Wing, Gangavati. She has organized many free cancer screening camps for ASHA workers and municipality workers. She has won National Builder Award by Inner Wheel Club in 2016-17 and President Appreciation Award by IMA President during Medicon 2021. Next slide. Dr. Vijay Manohar Revankar is the professor and unit and head Department of OBG, Kasturba Medical College, Mangalore. She is an undergraduate and postgraduate teacher, published many articles in national and international journals, has been the former treasurer and executive committee member of MOGS and life member of Foxy, areas of interest being non-distant vaginal hysterectomy and high-risk pregnancy. Next. Dr. Mohan Bhatt is the assistant professor of OBG, Yenapoya Medical College, Mangalore. Next. Dr. Shubha Ramarao, who is the president, Bangalore Society. She has been the DNB teacher for the last 32 years, being guide and examiner. She is a senior consultant and head of the department at St. Martha's Hospital, Bangalore. She has been life member in BSOG, AGOI, and BMS, faculty at several national and international conferences. Welcome, madam. Next. Dr. Nirmala Reddy is the medical director and senior consultant, Green City Hospital, Bangalore, with special interest in instrumental deliveries, preventive oncology, and gynec ultrasound. Next. Dr. K.S. Lakshmi, presently working as associate professor in Department of OBG, BIMS, Belagavi. She is the nodal officer for comprehensive abortion care in Belagavi district. Has won the Best Nodal Officer Award in 2019. She has 10 publications to her credit in national and international journals. Dr. Hema Patil is unable to join us today. She has left for an emergency. Next slide. Dr. Sujata is a postgraduate, done a post-graduation in OBG in 2012 at GMC Kottayam. She has won Young Talent Award 2013 AKCOG in Kannur in All Kerala Conference. Participated as faculty in first Yuva KSOGA 2017 and many Foxy international conferences and national conferences. She's a guide for your undergraduate and postgraduate research projects since 8 years and has more than 15 research papers to her credit. Next. Dr. Sangamitra, our last panelist, is an assistant professor in Department of OABG, KMC, Manipal. I welcome all the panelists and our expert for today, Dr. Bharti Rajshekar, and I hand over to Dr. Sadhana Gupta. Madam, you are muted. Please unmute yourself.
Dr. Hema is also there. I'm seeing her in the participant. She has gone to one cesarean emergency as well. So a warm welcome once again. And Dr. Shailja will be taking the lead in panel, and with all the discussion, right from the technique indication to the postpartum care. Let's go straight away to the case situation. So welcome all the esteemed panelists and Bharti. Bharti, you are our favorite expert because you give so much input, and that is so valuable. So it is also, we will what is a cesarean? It is a safe way, it is easy way on the part of us, on the part of patient. But always we find the unpredictable, difficult and dangerous situation. So before we go to the the difficult case situation, we are putting two questions to us that we have to be with the point that our battlefield should be well equipped. Where we are fighting 24/7, our battlefield should be equipped. So two questions. So first to Dr. Shiv Kumar and Dr. Manjula, that what type of anesthesia you prefer for the cesarean section, and how our cesarean section OT should be equipped for dealing all the diverse situation which we find off and on. Dr. Shiv Kumar, Dr. Manjula.
Madam, usually we prefer regional anesthesia, either spinal or epidural, madam. If the patient is obese and if we require prolonged time, we prefer a epidural anesthesia. Otherwise, spinal works in most of the patient. But in certain high-risk cases, as in case of eclampsia, severe PH, antepartum hemorrhage, in these conditions, and when the patient's platelet is low, we prefer a general anesthesia.
So thank you, Dr. Manjula, your comment about it. So rightly says, and few things which we actually have to say. One is the patient's request sometimes. Any backache problem and platelet, that is very important, that if the anesthetic association says that if it is the 80,000 is they have the alert when they don't want to give the regional anesthesia. So this is very important. So Dr. Manjula, your comment. And
yeah, madam, as you rightly said, if patient has previously undergone any spine surgery, or she has got a defect in the spine, or she's a case of cardiac case, I think then general anesthesia is preferred. And coming to the, as you rightly said, our OT is supposed to be a battlefield for us, and rightly we should be well prepared with all the emergency drugs. Any OT will be having all the emergency, but obstetric OT needs to be with the all uterotonics, and also emergency instruments like Bakri balloon, SR cannula, and mixture and retractors, especially an obstetric emergency bin which is prepared for the hysterectomy or ligation of the internal iliac artery, or all these emergency medicines and instruments, and also for receiving the depressed baby, baby resuscitation. All these things should be prepared 24/7.
So thank you, Dr. Manjula, for coming that we need to have the special drugs and special neonatal station and the special equipment for the unforeseen situation which we are dealing. Dr. Vijay and Dr. P. Mohan, your comment that how our cesarean section, what is that in any place, any room or something is given to anybody can do cesarean anywhere. So Dr. Vijay and Dr. P. Mohan, your comment on it, that how our cesarean section should be well equipped.
Madam, our OT should be well equipped. There should be a anesthetist, and there should be a baby resuscitation. Pediatrician should be well informed, and we should need good assistant also, and good staff, nursing staff should be there. We
So
don't
that
have
is-
even seen anytime any complication can happen.
So that is beside that, this is special, like all anesthesia machine, because we are doing 95% of cesarean section in regional. But when the we have the just post-spinal convulsion, post-spinal anoxia, and in a seconds we have to switch to the general anesthesia. So all readiness, whether we are doing in regional, but the all drug for the GA should be very, very readily available to us, beside all oxytocin and this telephone connection, because all emergency we say call for help, and these call for help should be just like a very easily available to it. So this is all about the battlefield, and these are the papers which are the few situation which we commonly find as the difficult situation. And Shailja, you go ahead with the discussion.
Our first case situation is a third gravida rural woman with previous 2 cesarean sections, but the first section was a vertical incision at a rural PHC where the child expired. Second, transverse joint coin incision, child is active and healthy, 3-year-old. She has come to you with mild pain. She wants to plan her cesarean section with you. She is coming from long way and want in your facility since she has lost her first child. Her ultrasound report is showing 37 weeks gestation, cephalic, placenta upper segment, like a normal, hemoglobin 10 grams, other investigations normal. Floating head is there, fetal heart section is good. Is this an easy or difficult situation? What questions ahead would you be asking the patient? How do we optimize the pre-cesarean workup? And patient also wants to know where will be the scar this time. Dr. Shubha Ramarao, can you please take this question? Shubha madam?
I think, I was muted. I just unmuted myself.
Yeah.
So I would like to know, the first one was a vertical section, right?
Yes,
And
ma'am.
this vertical incision, and the second was a transverse incision. So what
Yes.
were the findings at that incision is important for me. Were there adhesions? Were there, any dissection had to be extra? Any scar extension? Incision extension was there while extracting the baby. All these details I would like to know. Also, how the wound post-operative, was there any wound infection or delayed wound healing? This is what I would like to know. And nowadays, yes, if I'm going to do this section, she has come with little pain. So I would like to assess whether she is in labor. And if she is already in labor, I would like to do the cesarean then and then. If she is not in labor, then I would like to plan it. If she has come in the night, I would like to do it in the daytime, having, a blood in hand, having counseled them completely about the possibilities of having problems while delivering the abdomen. We don't know inside whether it is the uterus is stuck to the abdominal wall, or whether the bladder is advanced, and whether there's possibility of any injury to the bladder, or if any, unlikely that a bowel would be stuck, but you never know, the uterus could be badly stuck to the abdominal wall. This is what we have been seeing recently. I don't know whether it is because of non-closure of peritoneum while doing cesareans, or for what reason, but the uteri are stuck very badly to the abdominal wall, to the sheath itself, because of maybe non-closure of peritoneum. Even the muscle is sometimes not brought together, which of course is very debatable and controversial. But our women have a lot of divarication, so therefore the uterus just prolapses and gets stuck to the abdominal wall. So having counseled her, I would go ahead with a cesarean, and I would take a transverse incision and not a vertical incision, because we are used to it, and some complication like maybe a bleeding or extension of the wound can be managed through that incision. So, and that is going to be comfortable. It would heal well, unless I find there is some problem with the vertical incision. If there's a hernia, which I would consult the surgeon, and if they are going to repair that simultaneously, then only I will take a vertical incision. Otherwise, I'll go in through a transverse incision over the previous scar. And depending on if there's a keloid or something, I'll excise the scar. Otherwise, if it is healed very well and thin, there is no need to excise the scar.
Aarti madam, your comments, please.
Well, at the outset, I thank Dr. Sadhana for giving me this opportunity. And in this particular case, I would say first, she has come pre-operatively. So I would like the radiologist to comment about the placenta, because if there is a placenta accreta syndrome, I may not be able to handle her in a single doctor hospital. Probably she requires tertiary care, as I think. So 2 cesareans with one proper number with a vertical incision, I would first ask for the placental accreta syndrome to be ruled out so that we can be prepared. The second point is, as
all that has been ruled out and she has just
Even
come
in 5 months.
Yeah.
Yeah, and the second thing is, as Dr. Shubha mentioned, the post-op recovery from the 2 previous surgeries. And because she has come from a place where she doesn't have transportation and accessibility to come when she needs to come, and she may land up in an emergency. I would, if she could afford it, and you're in a public sector, you could always keep her in the hospital a week ahead of her planned cesarean, because very often we see in rural setups, it is very difficult for them to reach. Even if the 108 is there, they fail to reach on time. And then in the, as when they can land up in an emergency, we have a lot of problems handling these cases in the middle of the night, especially when it is a small place. Anesthetists are not available, pediatricians are not available. So ideally, we try to put her in the hospital at least 4 to 5 days or a week ahead of her planned cesarean at 39 weeks, maybe.
I would also counsel her about a concurrent tubectomy. And really, if she really desires, we can definitely go ahead with tubectomy. However, personally, I would like that child, since she has only one living child, I would like her child to be immunized and, grow up to at least 1 to 2 years. It's a social, it's my, this thing. Before I say, ask her to do a permanent method of sterilization. Because
you can go for a PPIUCD. I would go for a PPIUCD or an injectable rather than advising ligation.
Yes.
So thank you. Actually, Dr. Shubha and Dr. Bharti's input has raised many points. So one thing is like we should be closer to the term, and yet the social and everything has to be taken, that what is the plan, and people are ready for, like they come and they want to get cesarean. They don't want to be waiting and having all like issues for the hospital expense. And Dr. Shubha has also brought out that 2 very important, that the closure of the parietal peritoneum. So Dr. Shubha actually pointed a little bit that she is a little doubtful that non-closure of parietal peritoneum can lead to adhesion with her personal experience and a ligation. I think every panel will agree the one child is only alive, that it is like we don't know the behavior of this child, which is like after elective, and always better to have the spacing contraception. And the surgical, what is the additional surgery? Actually, Dr. Shubha has taken so many things which we have to cover, that if the hernia is there, that is the right time. We don't wait for the second surgery, and it can be easily done with the availability of the surgeon. So great input by the all panel. And now is coming to Dr. Lakshmi and Dr. Hema, if she has joined, that while peritoneum we are approaching, and what Dr. Shubha was feared, a lot of adhesion, and you are not able to access to the lower uterine segment. So Dr. Lakshmi, Dr. Hema, your comment before we go to expert.
Madam, opening, if we get dense adhesions between between rectus sheath and rectus muscle, first we have to go by sharp dissection. And we have to make a window, and we have to open the parietal peritoneum as high as possible. Then we have to open the parietal peritoneum, and we have to make a space over the lower segment. And if bladder is densely adherent, we have to go by sharp dissection, preferably scissors, and we have to push the bladder down. Then we have to take an incision on the uterus.
So well covered. And our Hema is with us or not? I think she has joined from the outing. Bharti, your comment about it, and it is almost well done. So
I think she has covered. She has covered all the points. Ideally, you would go either laterally or above. Go well above the incision, so you get a window where you can enter and try to dissect the bladder well away with sharp dissection. I think that's what you need to remember.
So
by
that
sharp
is
dissection.
yes, virgin space is important and a good assistant. What just now the one like our panelist says, na, the good assistant. So that need really good assistant, good traction, counter traction, and the simultaneously hemostasis, cauterization, and that is very very important. And always, Dr. Shubha said, we don't know whether we find the bowel adherent or the bladder. So very very important that always feel that it is any thickening that don't go to the that space. So very well taken.
Many a times it automatically becomes an extraperitoneal Caesarean section. The moment you open, you are on the UV fold when the uterus is adherent to the parietal peritoneum.
Yes. Great.
The next situation would be floating head. In previous, this question will be to Dr. Sujata and Dr. Sangamitra. How would you deal it if it is a floating head?
So floating head, this one previous to Caesarean section. So it is actually very difficult to tackle this situation. Floating head usually tends to slip. Okay, so what we are supposed to do is best is the thing is you can ask the assistant to stabilize the lie. That is most important. I would rather give an incision and I'll allow the liquor to drain a little so that head will come into that pelvic. Okay, then I will put my hand into take out the head. Meanwhile, you should be also meticulous here because what is that fundal pressure, like fundal pushing also sometimes may be required, but you should be make sure that the lie of the baby is longitudinal. If it is slipping from the head, if the fundal, then it will go worst. Okay, so it may slip. One is this one. So suppose one more thing is I usually carry the outlet forceps to the Caesarean section for a mobile head. So if it is what is the thick lower segment, unformed uterus, okay, so that it is difficult to catch hold the head. So I can use the forceps here. Most important thing is both the blades of the forceps is important. So you should both are required. Okay, you have to apply one below and the other one above the this one head and make sure it locks. Okay, so one more thing, important thing is for any section, Caesarean section, first is you have to do an ultrasound to find out where is the fetal back. That is most important because it will help you to lever out the fetus correct way. Okay, avoiding the extension of the fetal head and all those things. Okay, but some of people they'll use even the handheld cup also, that is Kiwi's cup, where you can manually create the pressure. And most important thing is you should know that you should apply this Kiwi's cup as close to occiput. Okay, as close as possible to the occiput, so that you will maintain the flexion and bring it to the incision area and you can deliver the fetal head.
Yeah, correctly said. That is the Wrigley forceps or Short-Simpson forceps, not our regular outlet forceps we use for vaginal delivery. There's a specific forceps for Caesarean section, Wrigley's forceps, which is very convenient. There is no left or right for that. Any blade you can insert first posteriorly and then above. You can maintain the flexion of the head of the baby, bring the head to the incision and deliver controlled delivery of the baby where the scar will not get extended. Your incision will not get extended. Bharati Madam, your comments on this?
Well, in my experience, I regularly use the Kiwi cup or the handheld small cup for the Caesarean. It's always there on my Caesarean table. And my experience with the vacuum has been very good. And I have not seen, as mentioned by certain studies, that there is an incidence of cephalhematoma and all that, because the amount, the suction we apply and the time of the suction we are applying is very, very minimal compared to a vaginal vacuum delivery. And so far, I have not come across any complications like extension or a depression or a cephalhematoma or maternal injuries. I am more comfortable with the vacuum rather than with the forceps, which I was using long back. But nowadays, I'm very much comfortable with the vacuum. And as Dr. Hema said, let out the liquor slowly, put a small incision, fix the head properly, flex it, and then be careful that your assistant does not give too much of fundal pressure. Sometimes they're so enthusiastic in fundal pressure that the head just slips and it becomes a transverse lie or a breach. So you need to be careful about that.
Sometimes even anesthesia colleagues also will be in help.
Yeah.
We want to keep, so they just push. So you should not allow
Too much of pressure. Too much of pressure is not required.
longitudinal lie. That is most important. Stabilize and then you can give the fundal if required. Okay.
So very important point you
not to be helpful.
So the very important point that identify the back on ultrasound, that is very important. And Bharti and Dr. Sangeeta, both you said that is a handheld Kiwi's vacuum suction pump. And actually what we're saying that the routine vaginal vacuum pump might cause some problem because it is perpendicular and it is for the different direction, but that specially designed Kiwi which is acting tangentially and that makes it. And that point we want to bring that it is not a regular vacuum cup which is that safe for the floating head. Any comment about internal podalic version for the floating head?
So Sangamitra?
If it slips.
Sangamitra, you rename also yourself so that.
Hello, ma'am. Am I audible?
Yes.
Hello. Yes, I think directly it is not required all the times to directly go for internal podalic version. Obviously, all of you are very senior to me. I do not think I have seen more cases of mobile heads than you people have operated. But I think it is not directly not recommended to go directly for internal podalic version. Yes, sometimes we have to be ready to go for internal podalic version, but that should be a second option. Delivering the head, keeping the vacuum ready or forceps ready as per the surgeon's convenience, or letting the Leica out, taking the help of the assistant, all these things become primary and the internal podalic version becomes a secondary when it's the last resort, according to me.
Internal podalic version, actually what to my experience, if you like to comment of Dr. Bharti, sometime when it is floating, sometime it turns into the transverse lie, and that is the time that we have to
when it becomes unstable. Yes,
suddenly it becomes transverse lie.
Suddenly while we're even after levering the head out, sometimes it slips and goes back into the abdomen. That's the time when we require
you should catch hold of the leg. Don't
and
touch
that's
the
leg. Yes.
You know, that may happen for a second of twins sometimes.
Yes,
when suddenly there is a uterus doesn't contract very well. There's a little lag for the return of uterine contractions, and you do rupture of membranes, and suddenly the baby would have turned by itself. Or you do a podalic version. If it has become transverse, you try to hold the breech and bring it out. And of course, see, when you're opening the uterus itself, I don't think you need a scan machine then to define the back, because the position of the ear, the pin out. The only thing is, I think no panic should be there. You have to be very calm and promote flexion of the fetal head and apply the forceps or whatever you want, or by steadying the head in the transverse position, a little bit of pressure, you're able to lever out the head better. When it is posterior, it becomes a little difficult, but when it is anterior position or it is transverse, it's easier.
Whenever the uterine segment is
oxytocin controlled infusion so that the uterine contraction brings the head into the incision line.
Now, prophylactically, of course, as soon as we deliver the head, we do give carbetocin or oxytocin. But no, I have never tried the method of giving prophylactic oxytocin just to bring in the uterine contractions. I think these maneuvers which we have just spoken about and use of the forceps or vacuum are good enough.
Thank you, madam. When we are going ahead with the third cesarean with Fanon style incision, if while dissecting the bladder, you see the Foley's bulb in front of you. Dr. Shivakumar and Dr. Manjula Patil, how do we deal with the situation and how do we prevent such a complication? Shivakumar, sir?
Manjula, madam, can you take?
Yeah, thank you. We should always feel whatever complication we feel, it's okay to have it. And with confidence, complete the extraction of the baby, close the uterus, then properly assess the injury, and then close the bladder with a 3-0 or 4-0 vicryl in 2 layers, and then pushing the methylene blue from down, just confirm that there is a proper sealing has been done, and keep the Foley's bulb for 15 days, 2 weeks. That should be fine.
Yeah, correctly said.
Dr. Shiv,
Identification is more important. You should
More
identify
important.
that you have injured the bladder. There's nothing wrong in injuring the bladder. You should be able to identify and suture the bladder with bold stitches.
Yeah,
Bharti
not
madam,
to
you-
panic.
Document. Never
Document
forget
and not
to
to panic.
document.
Yeah.
First thing is don't panic. Second, complete the procedure and document it. And medico-legally, of course, the gynecologist can repair the bladder. But if you have a urologist, no harm in calling in the urologist, and post suturing the bladder, you can do a cystoscopy, and you can see the trigone. You can see the ureters and the reflux of urine. And very important, please document and discuss the issue with the attenders and the patient herself, and tell them that it's going to heal. She just have to keep the catheter for about 2 to 3 weeks, and she should be fine. This is also medico-legally very, very important.
Any
But
comment,
look into
Dr.
that.
Shiv Kumar, Manjula and Bharti says complete the procedure. Do you want to put stay suture so that we actually doesn't get lost when we are delivering baby, so that we identify where the injury has been? And the extent, like from the very beginning, if it is on the dependent portion of the thing, then the urologist should be with us by the time we deliver the baby and close the uterus. But if it is like in a the safe area, then we can, most of the gynae can do it. Any comment about the putting stay suture and the identifying which type of injury we have actually done? It is a regular dissection or it is by the knife or something? Dr. Shiv Kumar, your comment.
Yes, madam. Identifying the injury is very important. So when you are anticipating it is a previous 3 LSS, before surgery only, you should anticipate that you may damage the bladder. When you anticipate, the damaging the bladder or any injury will be less, and your dissection should be very meticulous. And fortunately or unfortunately, even if it is injured, if you can identify the injury, you can put a stay suture and remove the baby as early as possible, and close the uterine incision, and then you can close the bladder and retest it with methylene blue.
So thank you, but Dr. Bharti have actually emphasized that doing injury is not like that. It is like Manjula says very nicely. I like that word. If you have it. But the documentation and identification is important, because whatever in life you have it. There is no way, and all the preventive measure what we have been sent. And Sharja, go ahead with we will finish within the
second
15
case
minutes.
situation is the 5th gravida, previous 4 vaginal deliveries at a village PHC. Had only 2 antenatal checkups. She has come to your hospital at 11 o'clock in the night with 40 weeks of pregnancy, with BP 140/94, dehydrated, anemic and tired. Fetal heart rate is only 100 beats per minute, with symphysia of fundal height 40 weeks, pulse rate 110. Abdomen is tense and presenting part cannot be made out. On pervaginal examination, os is 9 centimeters dilated, head at +1 with caput 3+, thick meconium found and vulvar edema found. Will you take her straight away to the OT or have a protocol for quick preoperative preparation and check in cesarean section in second stage? What difficulties you will anticipate and how are you planning and to face or approach these difficulties? Dr. Vijaya Revankar or Dr. Mohan Bhatt? Dr. Vijaya?
Well, madam, first I will take the recessive measures and send the necessary investigations like hemoglobin, all other things. Then I will discuss with the patient party regarding the complications. Then already she is 9 centimeters dilated, 4th gravida, and already head is on the +2 station. It is meconium strain. I will explain the risk of the baby also, because there is a more chance of fetal asphyxia and fetal distress. So then I can start pitocin, she may deliver, or I can apply I can do the instrumental delivery and deliver the baby. Not possible, then before itself I will arrange the blood products, because she's more prone for PPH after the delivery. Then suppose delivery is not happened, then I have to do emergency cesarean section.
What difficulties you'll anticipate and how you'll prepare to face them?
Because already head is she may be in obstructed labor patient, because pulse rate is 100 and the head is on +2 station, 3+ caput is there. So I will discuss with my anesthesia colleague. I want proper muscle relaxation, and then I have to make suppose I am doing emergency cesarean section, I have to make the vertical incision on the abdomen. Then on the lower segment of the uterus, I want to give transverse vertical incision or inverted T-shaped incision to deliver the baby. And then I have to.
Yes, please go ahead.
Then she's more prone for PPH also, atonic PPH. I have to take care of that also with the use of medical management I want to do.
So one or two things in that obstructed labor refer to that. So comment from Dr. Bharti and Dr. Shubha that we want to do the cesarean as SEP. But what was the point that even we are wanted to do maternal distress, fetal distress, referred a lot of exhaustion, even for the emergency cesarean section, we must have a quick analysis, because 2 times rarely we have faced with the detected diabetic acidosis and sometime anemia, because we are in a rush, because it is an emergency for everyone. So one point this, and second few thing what madam has said, vertical incision is everybody's choice and the inverted T. So 2 point which is the gray area that we can go ahead with the transverse and not inverted T but liberal. So Bharti, your comment, and Dr. Shubha, you can also, yes.
Yeah, thank you, Dr. Sadhana. First is the emergency check has to be there, rapid hydration of the woman, and I would always call for help. I would call one of my colleagues to be with me in this situation rather than doing it alone in the middle of the night. We will inform the blood bank that necessary blood may be available. I will try to have extra staff on the head end as well as on the surgical side to help me out in any complications. And then I would go with a transverse incision a little higher up on the skin incision as well as the uterine incision. Also, I would go transversely, but I will go a little higher up because she's almost fully dilated and the head is deeply, it's almost at +1 station. So we may have difficulty in disengaging that head end. So we will have an assistant scrubbed and washed up if necessary to give us a push from the vagina to deliver the head, and the neonatal team to be ready, and blood has to be ready. And I would call for help because I need somebody else to be do the talking to the patient as to the patient's attendants about the baby's morbidity and the maternal morbidity, and we carry on with our work. So I think we need to organize a team before we take up this case, which is very, very important.
So thank you. So it should not be in a hurry what we are really carried away. So Shubha, this is patient, this is. So the Bharti is for the transfers. So many times, most of the time we can have the transfers and it gives us better access to lower uterine segment. So that is, and the very important dictum to call that deeper, lower the head and higher the incision. Otherwise you are just entering into vagina and all the things like bleeding and the traumatic bleeding. Shubha, Dr. Shubha and Dr. Nirmala.
I would also take a transverse incision. And in such cases, you can expect the head to be, I mean, it is deeply impacted. So your uterine incision should be just above the bladder, which will probably be distended and, you know, it will be appearing higher. So don't push the bladder down, because the moment you push the bladder down, your incision is going to go onto the vagina. And then, as Bharti said, I would have somebody ready with gloves just in case they need to push it up. Otherwise, you can use a forceps as a vectis, or, you know, all this has to be quick thinking. We may even deliver her by the Patwardhan's method. If the back is anterior, then Patwardhan's method also can be used to deliver the fetal head.
So Patwardhan is something actually back anterior. Sometime it is due to the out of compulsion because the shoulder is already coming or the hand is coming and we have to be knowing a little bit because Patwardhan we say, but like what we say in Maharashtra's association where the Patwardhan belong and the few very senior teachers says that I have been called so many times because of the attempted Patwardhan maneuver. So it is something to be practiced and rehearsed actually. It is not that easy. However, the pull and the internal podalic version and pushing from the below is something what we are all doing. But Patwardhan is something that really you have to have certain experience in the certain situation. Any quick idea that any use of IV nitroglycerin or something you try relaxing? Manjula, your comment, any idea if you are using? And internal podalic version, no.
No, madam. No, madam. I'm sorry.
So we have also not used.
We can do the reverse breech extraction. Yes, I have done. We have done the reverse breech extraction. It has helped, especially if it's not a very big baby. Yes.
So
you try
whenever
to catch.
something is got wrong, finally putting like taking hold of the leg is sometimes which really helps it. And the study says that it is actually very good. It is in all the literature. It has put a good role that it is fast, it is easy, and it helps. So all about Patwardhan, and these are the few new things we don't know that that it will help. Yes.
I feel in occipital posterior, especially when you're doing a cesarean section for an impacted head in occipital posterior, I think that's when the reverse breech extraction actually helps you more. We'll be able to pull the leg out easily because most of the times whenever I try to go in for an occipital posterior, we'll come across the fetus face, nose and all obstructing our way to go beyond the head. And the asynclitism is also sometimes that also troubles us in occipital posterior. The rotation will be little weird. So I think in occipital posterior reverse breech, I felt it helped me a couple of times whenever I was struggling with delivering the head out.
See, when it is occipital posterior, sometimes a little push from down also helps. When you have to gently push the head up and flex it. You have to flex it and rotate, and then only you should extract. Otherwise, you will have bad colporexes, extensions happening to the sides, and we'll be in a big mess. Suturing becomes a real problem. So I think it's a matter of practice, or what you have seen, what you have learned from your senior probably will help you to deal in such a situation. And a uterine relaxant, it will be helpful only when the uterus is retracted badly, especially when there is PROM and you're trying to induce and it takes longer time. Then you decide on a section. Uterus could be badly retracted over the fetal parts, and it becomes really difficult to extract. That is the time when some relaxant will help.
Great. Shalja, go ahead.
One case, Lakshmi, when the baby has been delivered, suddenly the field is full of blood. When you wish to start suturing the uterus, you find it difficult to even track the uterine edge. How would we go about it?
Madam, as Bharti Madam said, first we like to call for help. As Madam already told, we should call for the extra help, and we should try to find out the edges. Sometimes when we tell the assistant to push from below, there may be extension of the, especially when we take the transverse incision, there may be extension downwards vertically. So we have to catch hold of the angles. Most of the time it will be the left side angle which will be extended downwards. So then we have to start suturing. Main thing is, important one is we have to catch hold of the apex of the extension. Then we should tell the anesthetist to give extra oxytocics. This one we have to send the blood for cross matching, and immediately we have to start transfusing the blood. Here main bleeding will be because of the extension, and sometimes there may be hematoma formation. So in that we can go for the uterine artery ligation. So ascending uterine artery ligation, if it extends downwards, we have to go for the descending uterine artery ligation. So uterine artery ligation, most of the time it will help in controlling the bleeding.
The first thing I would do is ask my assistant to put in 2 mops and give pressure or hold the angle.
Aortic cable, I would exteriorize the uterus Use the Paley's aortic clamp. You can always have the Paley's aortic clamp and apply iotocaval compression, exteriorize the uterus, and apply pressure on the uterine arteries. Ask your assistant to apply pressure on both the uterine arteries. And then without panicking, I think you have to start tracing the edges by putting tenaculum or forceps all along the edge. And then you will be able to find out the vertical tear if there is one there. I think I would proceed like that.
Yes, important thing is that don't rush to start suturing because everything is in mess. First, you take your time, you visualize that where is the injury and go slowly. So, and at that time, a good colleague and a good assistant help. Important thing is that don't go in the rush. Most of the time, we are able to identify injury if we identify. And sometime in the hurry, the posterior wall is also sutured to anterior. And finally, we know what is happening and it is a thing. So don't be hurry, extend what is the tear, and sometimes there are posterior hematoma and that the exteriorization and sometimes uterine devascularization help so that you have a little bit clear field and you can go ahead. This is the paper from like RCOG that most of the senior resident in UK, they are not comfortable with dealing second stage cesarean complication. Maybe we are better, but we also have to have a good training and the teaching. We will be like having 15 minutes or quick, like a rapid fire sort of thing. Yes.
Madam, actually, the thing is, we ask the assistant to push the head from below. That assistant should know that where is the occiput and all, which way push. It is not the single point. It is that they have to insert at least 3 to 4 fingers, try to catch hold the head and then push. Okay, that is important because it's point pressure.
One more thing is for controlling the bleeding. You know, some of us still have the green Armitage forceps in our hospitals. So, you know, it is important to have it on your trolley and not ask for it when she starts bleeding. So you can use the green Armitage forceps and to help control the bleeding.
Green Armitage must be part of every cesarean OT actually. Yes. Every cesarean trolley, forceps and a green Armitage is the must what we have. We will be having quick discussion, I think 15 minutes. So Shalja, you go ahead with this. Anterior placenta previa, not accreta. Today we will not discuss accreta. How to in anterior placenta, Dr. Sujata, Dr. Sanmitra, how to give incision. So quickly we will take few things. Yes.
Dr. Sujata, how would we deal with the previous cesarean with anterior placenta previa? What would be the incision over the uterus and how to deliver the baby? After delivery, when placental bed starts bleeding, how do we go about it?
Before planning for cesarean section, this is placenta previa. It is better to do a elective cesarean section. That's 37 weeks. One more thing is you have to do a mapping of placenta. So exactly you do an ultrasound from where to where the placenta is extending, that you need to know. Sometimes if it is anterior lateral placenta, you can go little more towards the other side and you try to push the placenta away, then rupture the bag of membrane, and you should be ready to tackle the floating head that time. So usually the presenting part won't be fixed in that placenta previa. So some of the times what will happen if it is exactly anterior and involving the lower segment where your incision is, okay, if there is no adherent placenta, you have ruled out it is not adherent placenta, sometimes you may have to cut through and go through and through placenta, and you should be very quick in delivery of the baby and also clamp the cord immediately. This is the condition where you need to clamp the cord immediately, because the bleeding from the when you cut the placenta is from the fetal side. Okay, so you need to take care of it. So again, placenta previa, there is increased chances of PPH and all. You should be arranged for the blood and everything. So preferably to do as an elective cesarean section unless the patient comes with antepartum hemorrhage.
So great input, and I say that the placental mapping and even the ultrasound has been done 10 or 15 days ago. It really helps if we do our own ultrasound night before, and we actually know where is we are going to have the incision, and God forbid any sign which gives us that it may be accreta, because in that case we don't have to give not oxytocin. We just have to see that it is manually separating, because 2 or 3 cases from the confidential inquiry of maternal death, that it was a non-accreta on the ultrasound, but finally it came out so that the readiness actually matters. So very well covered. Either we go separate, like we go beside placenta, or if if we are not able to do, then we have to be very, very fast. So Shalja, go ahead. We will be take as a rapid fire next. All
Aarti madam, there's a question. If in occipital posterior position obstructed labor on uterine incision, we see the shoulder at the incision level, which method is helpful? With push technique, we are not able to disimpact the head. What to do?
Pull technique. I think that is when we go for the Patwardhan technique, when the shoulder is already presented and it's coming out, and we'll have to do. So to learn to do the Patwardhan technique, I think we have to have mock drills and try to get the expertise of doing it, because as Dr. Sadhana said, Patwardhan technique is not that simple as it seems. It's quite complicated. So we'll have to have some drills during our sessions when we are free and try to master the technique of Patwardhan technique, because push technique will not be useful when the shoulder is already presenting at the incision.
True, and everything depends on the size of the baby.
Exactly. Yeah.
Labor impacted is a big baby generally. So the extraction is really difficult. You know, sometimes you feel, what are you doing? The doubled up fetus is so scary. You know, so that it is just experience and drills, I suppose, and not panicking is the most important thing.
Sometimes you may have to go for J-shaped incision also, where in that posterior, if you're not able to catch hold of this, you may have to do a reverse breach. You should have a plan B also. When plan A fails, then you should have a plan.
Reverse breach help is because you push again the hand inside the uterus and then again you put up. And because liquor is drained, sometimes it is not at all possible to put the hand because it is all something. So putting the hand again into the like a uterus and catch hold the breach, and always we have to be very, very cool about it. So
While opening up, if you see a significantly big myoma in the lower uterine segment, moreover 2 interstitial myomas on the anterior wall and 1 at fundus, Shubha madam, Nirmala madam, what would you do?
Yes. Good evening, Sadhana madam, and good evening to you all. I am a strong proponent of myomectomy during cesarean section. Now there are fibroids in the anterior wall, at the fundus, and in the lower segment. So if we come across a fibroid like that, immediately we have to put an incision in the lower segment. Now we can't even go up because of the fibroids being there. So immediately we'll have to do a myomectomy. I use a cautery, and I have done myomectomy after the extraction of the baby. Ma'am?
So we also do most of the time, but not every time. So you say na you are a strong proponent, and actually the surgeon always take decision in the best interest. So Shubha, and to you, that do you think that every time we have to remove, or sometimes
not always, when it is very close to the fund. Yes, in the posterior wall and close to the cornua, we need not remove it.
Yes. Thank you for that.
The lower segment, at the time of extraction, we'll have to go ahead and remove it and do the extraction of the baby.
So rightly said, it is a posterior wall or it is a cornua, then it is tend to bleed much more. So we have to take, first of all, one must be expert in the gynae myomectomy very well. And if it is you are doing it, then it is not always that you do always, or you give the false thing to the patient. No, we will always remove. We have to say, let's see. Once the baby is out, and let's see what happens. Shubha, Dr. Shubha, your comment about it.
So this is where, again, you know, how you mapped your placenta. Similarly, you must again recheck and see where the fibroids are. And our intention should be to deliver the baby quickly without causing any problems there. If it's an elective case, definitely you have time and you should not panic. You can remove the fibroids and then enter the uterine cavity. Otherwise, if you know that the fibroid is on the right lateral side, take your incision on the left, and then when it will be difficult to extend the incision, but once you get the membranes, then you can make a J-shaped incision and deliver that baby, and then do the myomectomy, because it's not as easy as we think, because you know a lot of hemorrhage can happen when you are trying to remove that myoma in a pregnant uterus. Once the uterus retracts, you know, after the delivery of the baby, then certainly the myoma also becomes prominent and the bleeding also becomes less.
And the continued use of oxytocin is must look that uterus remains contracted. We cannot afford the myomectomy in a little bit relaxed.
Yes.
And the tranexamic acid prophylactically is always a good idea to have. So these are my own
Carry
pictures.
tech, carbetocin.
Yes. So Sharja, last two, this is 32 week and the cesarean in obese women. This is the
Cesarean
last
section to be done for leaking at 32 weeks with severe oligamenous and transverse slide. How do we proceed? What type of incision on the uterus? How do we deliver the baby and the placenta? Anyone who wants to take this question?
Yeah.
I would take a transverse incision itself and make it a J shape. Ask the anesthetist to give some relaxant if necessary, because it's a transverse slide, and I would extend the incision towards the side where the legs are, because that is going to be, it has to be extracted as breech. And so I will extend it either to the right or left, depending on which side the fetal limbs are.
So one comment about at this point that sometimes you think of the vertical uterine incision, and secondly, right, the inverted T is not not a very desirable thing. Sometimes we have to the J and the U shape is the better if we want. So Shubha and Bharti, your comment that sometimes you opt for the lower vertical incision, so that if any problem we can extend that 31 week cesarean section. Shubha, your comment.
I have not taken a lower vertical incision, but when I have done a 32-week, this thing for severe preeclampsia, and it was a transverse slide, it was such a hell that I could not, because the lower segment was like a tube, and nothing I could do. I had to cut very vigorously onto one side and then extract that baby. And that was the time when I really thought I'm going to bring out the baby piecemeal. It looked as if, the legs are getting stretched, and it was really very difficult. I wish I had taken a vertical incision, but after that, I have not had a problem there.
So sometime actually when you think the vertical, because you can extend it easily vertically if you are really stuck. So that is a one option which we can do in a very preterm, which especially in IVF twin pregnancy, we are getting a increasing number of patients with this. So this is one thing. And Shalja, go ahead with this. And hematoma,
While you're finishing uterine closure, you see an enlarging hematoma at the lower segment going through the broad ligament. How do we deal with this? Dr. Sangamitra? Dr. Sujata or Dr. Sangamitra?
Okay, so here actually there is hematoma in the broad ligament. So what you have to do is you have to see if it is an increasing hematoma, then definitely you have to open it and you have to evacuate the clot, identify the bleeders. Okay, sometimes what will happen, if you identify the bleeder, it is always better to ligate that vessel, and you have to do an uterine artery ligation also if it is required that side. Okay, so if it is sometimes you may see that there are multiple oozers, you're not able to identify where is the bleeding point. Okay, so if it is a venous bleeding and all those things, it will stop by giving compression and you can wait. But definitely if it is an hematoma, you need to evacuate the clot and identify the bleeder and do a proper hemostatic suturing. There you can do an uterine artery ligation, and that will be helpful.
So Bharti, you are there, broad ligament hematoma is something. So Bharti and Shubha, we will like to have your comment. Bharti first.
Yeah, well, first thing is, as she said, we exteriorize, and if you can identify the bleeder, and we ligate it separately and see that uterine artery ligation and wait for hemostasis. Otherwise, I think we should not keep on procrastinating and waiting for the bleeding to stop and keep mopping or trying to put on this. I think we would go for an internal iliac artery ligation, because sometimes it is very, very difficult, especially after you evacuated the hematoma. It has already extravasated into the broad ligament. It is very difficult to identify the bleeders. So if you're not able to identify the bleeders, I think you should go ahead with an internal iliac artery ligation.
And any comment about the need of hysterectomy sometime that it in a very unstable patient, any experience of it?
Well, I have not had any personal experience on that. But I think we can always try the internal artery ligation first, and then in case the patient is deteriorating, we could always think about a hysterectomy to save the life.
If the artery has retracted, then I think internal artery ligation will be the Best choice.
Choice.
Yeah, and my worry would be about the ureter. You have to be very careful about the ureter. Push the bladder down as much as possible, exteriorize the uterus. And if you cannot get the bleeder, internal iliac artery ligation is what you have to do.
Yes, great. So finally, it is a cesarean in obese patient with a GDM and something. So any special thing, Dr. Shiv Kumar, Dr. Manjula, when you are doing cesarean in what we can say a markedly obese woman. First of all, the skin incision, that is a big question mark. And then again, any extra precaution, it is just like a little bit difficult cesarean. Dr. Shiv Kumar and Dr. Manjula.
In a morbidly obese patient, the problems start from conceiving itself, and when we plan for cesarean section for her, we will encounter many problems. First, our patient fitness should be good, so we should rule out hypertension, diabetes, and we should get an echocardiograph, and we should see that she is fit cardiacally. Then anesthesia is a problem for her. So problem starts from putting an IV cannula, and putting a regional anesthesia is also difficult, and doing an intubation is also difficult for them, and monitoring her during intraoperative by anesthetist is difficult. As far as our concern is concerned, we will encounter two problems here. First problem is accessing to the uterine cavity. For this patient may be, as you are seeing in the figure, she may be morbidly obese with the apron-like incision. If the apron-like incision is not there, I prefer to hold two assistants and pull the panniculus upwards and take an infrapanicular incision in most of the time. But if it is an apron-like incision like this, we have two options. We can push the pannicular upwards and take an incision, but that will cause cardiorespiratory problems for the anesthetist. Otherwise, we can pull the panniculus as much as downwards possible, and preoperatively, by pulling the panniculus, we may mark a landmark for the pubic symphysis, or lower uterine segment by ultrasound guided, and we can take a suprapannicular incision, which should correspond to 2 centimeters above the pubic symphysis or lower uterine segment. Sometimes that incision might be infraumbilical or supraumbilical, and after putting incision, it is very difficult to access the lower segment. So we should have good anesthetic relaxation, and we should see reach the lower uterine segment, and you have to retract the bladder. Once you retract the bladder, again the problems starts in obese women, because they may be associated with diabetes, they may be having macrosomic baby in floating yet, and we should take all the precaution to handle that. Sometimes what happens, there may be an IUJ or small baby in an obese woman because of pH or hypertension. In such a situation, it is very difficult to take out the baby, and once you take out the baby, it's very difficult to close the uterus, because we will be seeing in a deep cavity inside, and the uterus will be inside, and it is difficult to bring the uterus outside and suture. So you have to suture inside in the deep cavity, and taking very precautious and having a high level of patience. Once we close the uterus, we have to meticulously close the abdominal walls layer by layer, and we should take precaution to maintain complete hemostasis while closing the abdominal fat, because that may cause hematoma and wound seromas later. And if the thickness of the abdominal wall is more than 2 centimeters, I prefer to take subcutaneous stick to occlude the fat. Then I will put the mattress suture. And once you put the mattress suture, depending upon whether she is diabetic or antibiotic prophylaxis should be taken. And these patients are more prone for deep vein thrombosis, so that should also be addressed post-operatively. In this patient, instead of prophylactic thromboprophylaxis, we may have to consider therapeutic therapeutic prophylaxis also. And meanwhile, we should also take care to mobilize this patient as early as possible. These are some of the
Very
problems.
great. So see, the obesity seems to be very, very complicated. Like GA is difficult, regional is difficult, opening is difficult, cosmetic difficult, and giving non-cosmetic incision is also difficult. So Manjula, your comment about this, Dr. Shivkar so very nicely said that we have macrosomic baby, we have microsomic, and the baby is crossing like a full thickness of abdominal wall. So great, Dr. Shivkant. It was simply great. Manjula, your comment.
Madam Sir, Shivkumar Sir has covered every aspect, but I would like to bring a proper table is also essential. Sometimes patients overflow the table. So having a
and we should require even BP of bigger size.
Yeah, BP cuff, table, and especially retracting that upper fold. I usually put 2 big alleys, tie the roller gauze, give it to the head side to assistants. So you require more manpower and a well understanding assistants, a big team, a good anesthetist.
Shubha, you have a Bangalore who have got so many corporate hospitals. Just let us know that how many people like a hospital have that bigger table, which is actually bigger table, bigger trolley. So we don't have, Dr. Shubha, your comment, because the Bangalore have so many like corporate hospital. Manipal is
those who do all these surgeries for obese people and all, I'm sure they have. But in my hospital itself, we have the standard tables. But one thing is, when we are operating on little fat women, in spite of keeping the table lowest, you are unable to reach. So you yourself have to stand on a stool to reach inside the abdomen. So that's one thing. So we have to have footstools ready for the surgeon itself to stand. However tall you are, you need to be taller than that patient. I can share one this thing with unfortunately one patient, 136 kgs. She knew that she was pregnant only when she was around 26 weeks. She thought her periods had stopped and she was only 38 years. She had had a previous normal delivery and one cesarean. So she was a third gravida. So she came at 26, 27 weeks, diagnosed diabetes with on insulin. And then she came in preterm labor around 32, 34 weeks and had to undergo emergency section. There were 5-6 people in the OT, including the surgeons who washed up and were helping with the, lifting the paniculus. But believe me, the extraction was so difficult that the baby was lost during the process of extraction only. It was a little big baby for the gestation, but she was 32 or maybe 34 weeks. It was so unfortunate. After that, she had wound infection, wound adhesions. This was during COVID times. And then one day, that wound has taken more than 2 months to heal. And one day she had big bout of cough and she came with the bowel coming out of the wound. And she was so breathless, maybe she was COVID positive. And then she went to the government facility, but frankly, felt very bad for her. It was very sad.
Something. Thank you for sharing, Dr. Shubha, because this is something actually we learn so many things from the life, and rightly you say that sometimes we really lose babies with a very difficult traction. Maybe whatever it is the cause, it is a transverse life preterm baby and this situation. So thank you, Dr. Shubha, for this share, which actually makes us at the end of the panel much more alert and need to be ready with all the things what we should have. So thank you for brilliant discussion. So no matter whatever we do, we always wish to achieve perfection. We tend to have the falters, we tend to have the adverse incidents, we tend to have the sad incidents, because we always aim to for the perfection. So no pressure, no diamonds. That is the thing, and that is the all diamonds of the panel are with us for the wonderful tips and tricks. And with this, I again seek everybody's support for my epoxy presidential candidature and brilliant discussion. And thank you, Sharja, for being together in working so hard for all the program organizations. So over to Sharja.
Thank you so much for giving me this opportunity, madam. Thank you to all the faculty, our chief guest, Dr. Caesarean, our guest of honor, Dr. Vidya Tobi, Manonmani madam, Dasari madam, and Dr. Sadhana Gupta for those wonderful, exhaustive lectures covering every aspect of cesarean section. Big thank you to Dr. Bharti madam for being our expert today, to all our panelists, and thank you to the delegates who logged in and stayed till now, till the end. And thank you, Sheel, Tulika, and Sahiti for that groundwork. Thank you very much, madam.
Thank you, Dr. Sadhana, and wish you all the best. Wish you all the best, Dr. Sadhana. It was an excellent panel, and Dr. Shailaja, you did an excellent job.
Thank you,
Thank you very
Bharti,
much.
and wish you all the best.
Thank you, madam.
All the best to Bharti madam and Sadhana madam.
Thank you, thanks, Shailaja.
Manonmani, thank you. Thank you, Sadhana madam. Thank you, Shailaja.
Thank
I
you,
thank all
everybody.
my
There is a
chairpersons,
question.
co-panelists, and all the
Bharti
faculty
madam,
for
there
this
is a
excellent.
question, last minute question. They say term posterior incision on the lower segment accidentally, how could it be prevented? From Dr. Pushpa Srinivas. But how did they give incision
On the
on
posterior,
I don't know. She's asking, given accidentally term posterior incision on the lower segment.
well, I think first we have to identify the
It must be
lateral,
a torsion uterus.
or the pedunculated in the panniculus. I think madam means it is very obese lady with the panniculus. If the uterus had acute anteversion and it has come forward, I think the first thing is we have to identify the bladder and the uterus before we put our incision. I think that's how we could prevent it, because you'll always see the bladder just on the anterior wall of the uterus. So that's what we generally do. We generally identify the bladder before we put an incision on the uterus. So I think probably anybody else could take the question, because I've never come across this
And
situation.
also look for the round ligaments. See to it that uterus is not rotated. Most of the times it will be rotated. Baby is average size, but patient not progressing because of the rotation of the gravid uterus. So derotate and then do the extraction.
So always we should be in the habit of correcting the dextro rotation of the uterus and see the round ligaments. Because normally round ligament will come into the center when the uterus is dextro rotated. Therefore, correct the dextro rotation before you take your incision. Otherwise, your incision will go on to the left and you will cut the uterines rather than,
posterior,
remaining in the lower segment.
Yeah, that answers your question.
Actually, great input by Dr. Shobha. In every cesarean section, we have to be careful before giving like quickly. One very important that is about paniculectomy. So in Dr. Deepa has said in the question answer. So in obese patient, can we do the paniculectomy at the same time? Any experience? So
I don't think we should do it at that sitting.
Thank you to all.
Though I don't have any experience. But in such a morbidly obese patient, I don't think we need to do an additional surgery at that time. She can wait and get it done later on.
See, definitely not at section, because the skin is going to retract and whatnot is going to happen. But when I was a postgraduate in Bombay at Kama Blessed, for a hysterectomy patient, it was a Sindhi patient. She was so very fat, and I can mention name, Dr. Vimal Parikh, had taken a huge panniculus out. But believe me that her post-op was so morbid, and her wound gave way. And my God, I don't know how many months we did dressing for that lady before we could even do secondary suturing. So, and especially
it's not advised.
One thing is we must always keep drains. We must keep drain in the subcutaneous space. Then only at least the wound healing will be promoted. And intra-abdominal in the UV fold, not a suction drain, but this thing
correlated
drains. That one we can.
So one thing, a very clear message, because in one panel we say that 2 or 3 people say that we do paniculectomy. So what a experience from Dr. Shubha that it is not the right time to add on with the add-on already added many issues in the obesity, and that is not the way, and go for the weight reduction and many things we can do postpartum. So the brilliant discussion. So Sharja, And thank you, audience, for a brilliant question that makes us very 10:15, around 10:15. We have so many inquisitive audience that we are having a lot of questions. So, Shailja, go on. I think you have done with your vote of thanks, no?
Yeah, man.
So, yeah, we can say good
Thank you all.
night.